much.
I'm sorry. I would like to introduce him. He is chair of a scientific committee of APAT, and he's from the Department of Clinical Toxicology, Lokman Hakim Hospital, Shadid Behçeti University, University of Medical Sciences in Iran. Okay.
Thank you very much for inviting me, and thank you very much for organizing committee to have this great conference and sharing our knowledge and our experience together. Okay. No, this is off.
It is off.
Could you please turn it on? Okay. No problem.
Sorry, Hossein.
Okay.
You have to turn your back. If you prefer to sit here, you have the screen.
No, that's okay. That's okay. Thank you. Actually, why we are trying to describe the methanol outbreak here, because the MENA region, including Iran, Turkey, Afghanistan, and other neighboring countries, are involved in methanol toxicity outbreaks from recent years, and we had a lot of fatality after those outbreaks, and we had no guideline how to manage them. So I'm not focusing on the personal treatments of every patient. I'm focusing on public health issues of methanol outbreaks and how we as a physician should deal with methanol outbreaks. So it doesn't work. Thank you. So I should declare that I have no conflict of interest. The importance of this issue is that if we work on the patients and if we treat them, we have a good outcome, especially in early hours. But if we postpone the treatment, we will face a huge amount of mortality because of the delay. And usually there are some prognostic factors that can determine the outcome. And on top of the reasons of those prognostic factors is significant delay of presenting patients to the hospitals. So why the patients are not going to be treated appropriately? Because of the knowledge of the physicians who are involved in treating these patients, and also because of lab facilities, because in most of the our lab infrastructures, we haven't had rapid access to determination of methanol in the blood or in the serum of the patients. So usually we act based on the clinical scenario, and also because there are some special concern about the patients. Many of them, especially in Islamic countries, are in fear of punishment, and they think that if they go to the healthcare facilities, they may encounter with police and on other legal punishments. Especially these stories happening in Iran, in Indonesia, and maybe in Pakistan or other neighboring or other Islamic countries. And also, we are not in the process of case finding for our patients, because usually we, as a physician, we usually just see the patients itself. We wanted to treat the patients just in the emergency department. We are not aware of the out of the hospital. We are not aware of the other people who may come to you. So somehow when they are coming to hospital, they are in a severe and bad position. So we should use our resources, we should use our hemodialysis machines, and in some cases that the epidemic is huge, you cannot use that amount of hemodialysis machines. For example, for 300 patients, you cannot use a lot of hemodialysis machine because your facilities and your resources are completely limited. So we should have a plan. And this plan can be extended to the other toxicological outbreaks as well. And also, there are some vague signs and symptoms of methanol toxicity, especially for young physicians and for unexperienced physicians who haven't seen such ill patients, because most of the time they can come in early stages. And unfortunately, we had such a problem that many of them released after coming to the hospitals, and and even some of them died after leaving the hospital because they hadn't had a good differential diagnosis in terms of their clinical manifestations. And also, lack of enough communication is one of the worst things that we as clinical physicians are encountering. We cannot communicate with our governmental side. We cannot warn them when and what is happening in the future. And sometimes they cannot rely to us because they are in fear of something else in terms of policy and the other stuff. So all of I think I can shout. Okay, thank you. Sorry. So all of those stuff may prohibit us from prompt triage and treatment in appropriate time. And you can see that in the next hours, the number of casualties will be increased dramatically because of lack of those stuff. I took this picture from 1 week ago, exactly at February 12th. We had an outbreak in south of Iran, and 27 patients were involved, of whom 7 died. And this was the responsible alcohol. This is an illegal alcohol that they were selling it in the city as an Acil vodka, and the price was almost $1.50 US, and in 500 milliliters. So many people were interested that someone was kind enough to them and offered them something good. So they start to drinking it, and you can see our patients over there that finally 7 died. This is a small example of a methanol outbreak. It is not just happening in the countries that alcohol is prohibited. It can be seen in even European countries. We had similar outbreaks in Norway, in Czech Republic, and also in the other places because of the tax of alcohol. So because the price of alcohol is high in those communities, many poor people prefer to drink non-standard alcohols. So drinking non-standard alcohols can create a methanol poisoning. I want to explain briefly what is happening in an outbreak. You know, here, when you're facing with just one patient, you may have all of things that is necessary for treating a patient, including hemodialysis machine and including antidotes. I'm not focusing on different antidotes, including fomepizole or ethanol, but most of the time we are using ethanol, and statistics shows that there is no difference in terms of outcome between those who use the fomepizole and those who use ethanol. Just using ethanol is more difficult because we should have regular measurements of ethanol for the patients, so it needs more close monitoring than using fomepizole. But the outcome is not so different, as I said, and as the literature actually shows. Just after a while, if an outbreak is happening, you will face a lot of people that are coming to your healthcare facility with no antidote or with limited antidotes. Why it is happening? Because we are not prepared. And because probably you have lost most of your supply in the past for treating of the patients who were not in need of those antidotes. This is our experience in using media to aware people regarding a methanol outbreak. Actually, almost 4 years ago, we had a large outbreak in central Iran. And in the first hours, we have noticed that content of illegal alcohol is distributed in city, and many people actually bought it and started drinking it. So a huge number of people were in danger of methanol outbreak. So after several cases that came to the hospital, we start to alarming the people by sending SMS, by using media including TV and radio, and even in some places by using loudspeakers to aware people that an illegal alcohol is distributed. And the result was very good, because out of 700 methanol poison cases, just 10 cases died. And this is the less, actually, number of mortality among methanol poisoning outbreaks in the world, just by public health concern. We had no access to fomepizole, just we had access to ethanol and also hemodialysis. So we invite several experts from all over the world to contribute their knowledge and their experience. Most of them were involved in previous outbreaks in their own country, to have a consensus guideline, an international consensus guideline, on how to manage a methanol outbreak. So we gathered together to agree on a definition of methanol poisoning and outbreak, and outline an approach to triaging a methanol outbreak, and define a criteria for prioritizing antidotes, hemodialysis, or totally extracorporeal eliminations, and also indication for transferring the patients. This is not the case for all methanol outbreaks. Sometimes you are in lack of enough facility, and the number of people that are coming to you to your center is much bigger than your capacity. So you have to call the other centers, you have to call the other colleagues and ask them to help you. First, we reviewed the literature and collect enough data from previous outbreaks, and we developed a Delphi method to see the opinion of different experts in different subjects of methanol outbreak. And you see the open label questionnaire that we collected to gather all the data. It was not a simple task. It takes around 6 years because of the huge difference between treatment strategies, and also because of different experiences in different countries. So we asked them to define the methanol outbreak. What is a methanol outbreak? How many people should be involved to call them it is a methanol outbreak? Because after defining a methanol outbreak, you should do something to aware the other people and to bring them to hospital in advance in order to prevent further consequences of severe illness. And we asked them if we should have an active case-finding strategy. We asked them to define who is responsible for case-finding and communication in this context, what method should be used for case-finding, and how to avoid overcrowding of healthcare facilities. It's very important to define an outbreak or not to define an outbreak. Because when you define an outbreak, you should be prepared, and many people may come to you, and you may overestimate the situation, and you may lose those people who are really involved. So it is very important to define it. And also regarding diagnosis of methanol poisoning, we asked them to define how to triage the patients, to prioritize them, because in those outbreaks, our facilities are limited. If it is necessary and useful, how can we triage the methanol poison patients? And also, if an outbreak is happening in a poor and limited resources area, what should be done? Are there any existing triage system in terms of outbreak, like something like poison severity score relevant to methanol, but we couldn't find? Are there any ethical implication for triaging patients? Because by triaging patients, somehow you know that you are reducing the chance of survival for ill patients because of lack of facilities. But you should decide. It's like the other triaging system. We should define who should be prioritized. And administration of antidotes regarding administration of extracorporeal eliminations, and also regarding transferring of the patients in special circumstances. So we asked them, the experts, to define the level of evidence and if they have any reference to their recommendations. So we categorized the consensus in 4 levels. Level 1 was strong recommendation. We recommend something if they agreed more than 95% of the cases. And we suggest something if it was between 19 and 95. And finally, we had another category. It was a neutral recommendation between 50 and 90%. And in these cases, it would be reasonable to suggest something for the other physicians. And finally, in some cases, we had no recommendation. So after a lot of rounds, it came to us that in order to define a methanol outbreak, we should have the previous history of methanol poisoning in that area. So an outbreak actually is defined based on what is happening in the past and what you expect in the same time, in a limited geographical area. If we haven't any data for the past, simply we make a consensus that more than 3% using methanol and affected by methanol, we would face a methanol outbreak if it is coming from a common source. In terms of, and usually it is happening within a limited time, usually less than 48 to 72 hours. And regarding notification of public and health system to the onset of methanol poisoning outbreak and active case finding, we suggest that the context of methanol poisoning happening, an active case finding should be undertaken. We should follow the other people that are not in the hospital, and probably they will come to the hospital in next hours. I can treat a methanol poison patient just by a drink of ethanol in early stages, but I cannot treat the similar patients if she or he came to me after, for example, 24 hours, even by hemodialysis, even by using fomepizole. So the outcome is completely different. So we should seek for the patients. We should not sit there in the emergency department, and we should involve the other institutions that are concerned about the public health problems of the region. And we suggest who should actually collect this data and warn the other people. We suggest that the governmental health authorities should be responsible for active case findings of poisoned individual patients who are not presented to the hospital. In terms of triage, it would be reasonable to use a triage system in the context of methanol poisoning outbreak, and we recommend this triage system should be depend on level of consciousness and also pH of patients on arrival time. Because these two factors are the main factors that can determine the outcome of the patients. I will show you in the next graph that how it would be affect the final outcome of poison patients. And regarding administration of antidote, we recommend that patients with a high probability of methanol poisoning drug are promptly administered an antidote, right? Further assessment is needed. Actually, there are some data, especially from Czech Republic outbreak, that those who actually drink ethanol before coming to hospital, they all survived and nobody was blind. It's focus, it's stress on the importance of early administration of antidotes. These days, actually, we as an Islamic country, convince our Ministry of Health to have ethanol as an antidote in the ambulances. It was very difficult for us to convince an Islamic government like this, but at least they know that we are using this ethanol in order to treat the patients. So they accept, fortunately, and I hope that we haven't had a lot of abuse from the ambulance crew. Even if it happens, it's no matter. In this case, they are using a safe drink. Yeah, we have it already in the hospital. So in the past, we could use the ethanol in the hospitals. But the problem is that when you want to administer ethanol to patients, you should determine that this is a methanol poison patient, and you have not enough facility to determine this is a methanol poison cases. So in these cases, actually, we are postponing administration of antidote to our patients, and the outcome would not be good. And we recommended that, this is very important, that's why I highlighted it. We recommend that antidote administration should occur in the pre-hospital setting, where possible. And also we recommend that in even both fomepizole and ethanol, if they are both available, but in limited supply, patients with more severe poisoning receive fomepizole, and that lesser poisoned patients can be given ethanol. Because the outcomes are the same, but monitoring of fomepizole is much, much easier than monitoring of administration of ethanol. Also, we recommended that patients who are pregnant or less than 14 years old should be prioritized to receive fomepizole. We recommend that sufficient amount of flumpizole, if available, the patients at high risk of toxicity but not current acidosis or end organ damage should receive flumpizole, because flumpizole can prevent hemodialysis. We recommend that in any patients requiring antidote treatment should be receive optimal treatment with bicarbonate, folinic acid, and supportive treatment as necessary. This is very informative graph, and we collect all the data from, I think, 7 centers. We pulled it all together, and you can see this beautiful graph. All the outcomes, in spite of using antidotes, depends on 2 main factors. First, on arrival coma state, and second, pH. You can see in the right side that those people who were not comatose, maximally 25% died. In maximum. You can see risk A, risk B, and risk C. These categories are those who were not comatose. And those who were comatose, at least 42% died. And when we merge them, I mean the comatose state, with pH, you can see those who had a pH less than 6.74, almost all of them died. You can see 83% died. And the remaining, I mean 70%, were blind, if they survive. So we have a big data of methanol poison cases that were treated, and that we could determine that, and we could categorize them based on pH and based on the coma state. And you can see, for example, if in group A, in a risk A group, if they come to you with a pH more than 7, and they are not comatose, just only 5% died. So we could determine that something is happening in the future, and we could have a plan to prioritize patients based on this categorization. So we had some recommendation based on those consensus and based on those facts. We recommended that use what you have. We couldn't determine that which country should use which antidote. It depends on the availability of antidotes and also based on your infrastructures. So our recommendations was a general recommendation, but it was a good guideline for people who are treating and who are involved in the different methanol outbreaks. We recommend that prioritize dialysis for those who had visual disturbances, particularly who are deciding between patients within the same group. Also, we recommended that those people who are in category 3. Category 3 means refers to actually the pink category. Is the highest priority for extracorporeal therapy in context of methanol poisoning if the dialysis machine is not enough and it's not available enough. And finally, the worst group should be the next prioritized group for hemodialysis. And group 1, that group that had the little amount of mortality, little rate of mortality, is the lowest priority for hemodialysis, and because we could treat them with antidote. And finally, those decisions about extracorporeal therapy follows the requirement that all patients have received optimal treatment, notably antidote, bicarbonate, and other supportive cares, and folinic acid. We had the same strategy for transferring the patients. Those can be transferred, who we can provide enough and optimal care during transfer, and who are not very severe and ill. And that was the general recommendation, and these guys are our co-author in publishing the consensus guideline on clinical toxicology in 2019. And if you have any question, I'm ready to answer, and you can refer to this references.
Dr. Hassan Hussein, thank you for your interesting presentation. And I would like to say that almost 2 months ago, our country prevented a methanol outbreak. They arrested the people who produced illegal ethyl alcoholic drink, more than 1 million bottles, and I think they prevented the big outbreak, methanol poisoning outbreak. Thank you. And I have a question about that. Do you have in your consensus guideline, do you have any guideline for dosing antidotes for both ethanol and fomepizole?
As I said, we are not. We have mentioned the dose, but it is a general recommendation. Just
general, yeah.
we were focusing on the public health.
No,
yeah.
do you have not any specific? Thank you. Do you have any questions, please? We can't hear, please.
Hello? Hi. I'm Dr. Razan. I work in Kuwait. You mentioned that you have ethanol in the ambulances. So are your paramedics actually trained to
We recommend
ethanol?
to have ethanol in ambulances.
Okay.
Not in the routine.
So you don't have it currently, but
Yeah, it's legal.
it is legal. So who is the person who
Drinking alcohol is not legal in my
yeah,
country.
I know, I understand.
Using alcohol as an antidote is legal.
Yeah, I understand. But I mean, are the paramedics trained to identify methanol toxicity?
In case of methanol outbreak, we are somehow over-treating the patients. And it is not a matter of issue. So no matter, because in an outbreak, we have to prevent further consequences, and maybe you are treating patients more than what is expected to treat. So actually, we expect to treat patients more than usual in an outbreak, and it's not a matter of issue. Because in this way, you're preventing, even when you're suspicious about the methanol outbreak, methanol poison cases, we can start ethanol as a treatment.
Okay, thank you.
Welcome.
Any questions? Okay.
Thank you for your presentation. I am Dr. Tariq Al-Rifai. I'm the past director of Syrian National Poison Center, the oldest poison center in the whole MENA-Tox region. I am surprised it's not represented in here. We have the same outbreak in 2003, was 127 cases.
Can you please talk loudly?
Okay, we have the same outbreak in Syria, 2003. It was 127 cases. It was homemade methanol, which is, I think it's a special situation because homemade is a mix of almost of 3 kinds of alcohols, ethylene, glycol, and methanol, and ethanol, which is make it toxic time bombs. Because the ethanol is there and the level which is not enough to prevent methanol toxicity. You know, we give ethanol up to make the serum level up to 100 and above. So the outcome was very bad. It was 25 died and similar number bilateral permanent blindness.
This is the problem of ethanol administrations because you have to, as you said, you have to measure the ethanol concentration in the blood in order to see if the enzyme is blocked and the methanol can be excreted without any change. So but in the other hand, the price of the fomepizole is very high, and you should take it in advance. I mean, you cannot wait if you have ethanol. You cannot wait to see, I'm looking for fomepizole because fomepizole is a better antidote. You have to start the ethanol.
Yes,
Whatever
of course. And the fomepizole, it's
yeah.
very expensive.
And we have some tricky ways to measure the ethanol level of the to measure the ethanol level of methanol poison patients. One of them is using the alcohol-based analyzers that are used by the police forces. You can ask them. You can ask them to bring their devices into your, for example, emergency department to use it and see what level of the alcohols are people taking.
Okay. And the last thing I like, the way you make awareness and alert other people, which was not in Syria. They prevent me even to talk to the media, even to, because there was the local authority, they prevent to do one single alert method at that time.
Yeah.
Thank you very much.
You're right. Thank you.
Dr. Megarban, you are the author for the methanol poisoning and fomepizole. You have lots of papers about that, and what's your contribution to this session?
Okay, thank you. We discussed about the useful antidote, the advantage and disadvantage of recommending ethanol versus fomepizole.
Mm-hmm.
There is no benefit in terms of efficacy, but ethanol is much more available. Fomepizole is a medicine. It cannot be delivered without a prescription. So we finally decided that it's better to recommend ethanol even in an Islamic country. And Hossein tried to convince his authorities to allow the administration of ethanol in case of a methanol outbreak, and this was possible, I think. I don't know if you experienced this possibility after our recommendations.
Not yet.
Because sometimes there is a gap between what is said and what is actually done. I have also a question regarding the possibility of diagnosis. Dr. Hofta assessed the usefulness of an easy method to measure the concentration of formate at the bedside and even on the scene using mantlets. And I think he was interested, or maybe he did it in your country. Do you have any experience with that?
Actually, it was run about 6 years ago, and we collect the data, what we haven't published it yet, using actually measuring formaldehyde and formic acid as a reflection of the severity of methanol poisoning, and also, but it's not market. It is not market, and also at the same time we were working on different possibilities of measuring methanol in alcohol drinks by some easy ways, and we could succeed. So, but we cannot market it because we cannot tell the government, for example, that we are now producer of something that encourage the people to drink safe alcohol. So we should define a tricky way. Anyway, and on the other hand, we were working on the measurement of the methanol in urine, and it would be available soon as a kit.
Mm-hmm. Is this test marketed in France?
Not yet.
No.
It's not marketed. It's a bedside rapid diagnostic test. It's not marketed.
Not yet, okay.
But you can contact Dr. Hofta, who is responsible for this research, and it seems that he tested it and it has no false positive, no false negative, so it's very interesting to make the diagnosis at the bedside rapidly.
Do you have any questions or contributions from the audience? I think that was a good session, and for getting learning lots of new things, and discussing together. Thank you very much. Do you have any
Yes, so now it's time for lunch, and we invite you to be back at 1:30 for the next two symposium. Thank you very much.
Thank you.
Okay, welcome back after the lunch break, and thank you so much for attending this panel discussion. We are going to be talking about international collaborations in toxicology, and we are tremendously honored to have 4 internationally renowned experts here to talk about these international collaborations. The first person who I have the honor of introducing is Professor Paul Wax. Dr. Wax has been the executive director of the American College of Medical Toxicology since 2008. He is also a past president of the ACMT. Dr. Wax is a professor of emergency medicine and toxicology at the University of Texas Southwestern in Dallas, and he will be the opening speaker to talk about our collaborations. Thank you.
Yeah, thank you very much, and it's a pleasure again to be here this afternoon. And if we could get the first slide. Okay, great. So as mentioned, I've been quite involved with the American College of Medical Toxicology now for many years, and I just want to go over some of the accomplishments and some of our vision for the future. I think I do need the So our organization has grown, significantly over the years, and now it's the largest professional society of medical toxicology physicians in the world. We have a total of about 800 members, of which about 2/3 of them are board-certified medical toxicologists. But we've also opened the society up to other important partner groups to work with over the years, including affiliate members who may not have board certification in medical toxicology, but are physicians interested in medical toxicology, or others such as PhDs or PharmDs, others with advanced degrees with an interest in medical toxicology. We also, as I mentioned briefly yesterday, have an international section as well, and this is a section that I feel it really has the opportunity to grow considerably. And I'd like to, invite folks who've attended this meeting to consider joining ACMT, and we'll talk more about ACMT over the next few slides. We also have a bunch of resident members. That's another category for those who are more junior, and also for medical students. So we do a number of different activities. One of our areas of focus, clearly is in the educational arena, and we've developed a number of programs over the years. Our major program is the annual scientific meeting that we have in the springtime. The meeting that's coming up is going to be in New York City just in a few weeks in 2020, and in 2021 we have the meeting in Portland, Oregon. We attract about 350 participants in the meeting. Most of them are members of ACMT, but we also have non-members as well, and it provides us an opportunity to present cutting-edge research and a series of plenary speakers. Many of them who are actually non-members are bringing new information and knowledge to the membership. Usually the day before the conference, we have a symposia which is targeted toward a wider audience than just the medical toxicologists. And this year we're doing an important symposium on opioids and some of the risk reduction and preventative measures, and we'll attract quite a wide diversity of folks to that session. I think it's really kind of a cutting-edge topic, and it's something that we need to keep abreast of going forward. And actually for 2021, we're already starting to plan a whole program on methamphetamine, which is kind of known as the fourth wave of the opioid epidemic at this point. Other conferences we put put on, including a board review course every other year to prepare for the board exam. The next course is going to be in Minneapolis in August of 2020. And now, dating back about 12 years or so, we've put on a series of forensic conferences. We've teamed up with colleagues from the Society of Forensic Toxicology and analytical toxicologists to provide a diversified approach to the challenges in the medical legal arena and toxicology. Usually they're very focused on one or two toxins such as ethanol or opioids or stimulants, and it's meant to impart an intensive training to medical toxicologists and others that may work within the forensic arena, something that's really, I think, useful for the expansion of medical toxicology practice. And we have a number of members interested in doing forensic work. And then, as I mentioned yesterday, we just started putting on this annual course, which is called our Total Tox course. And this is a 3-day course aimed at really non-medical toxicologists, but those who are interested in a comprehensive review course in toxicology. And it's brought together by really a distinguished faculty. Beyond the live courses, we've done a series of webinars, and our webinar program has really expanded greatly over the last few years. And now we're putting on a webinar a week, which is a lot of webinars, but there certainly seems to be quite a bit of demand for this. And this is something that folks can attend really any place where they have access to the internet and or a phone connection. Our main monthly webinar is our National Case Conference, where we discuss a series of interesting cases, but we also have a journal club, we have a grand rounds, and a couple years ago we added an addiction medicine webinar series as well. So this is one of the areas that we're continuing to push out education on a very frequent basis. In terms of the practice of medical toxicology, I mentioned some of this yesterday for those of you who were in attendance, but a lot of initiatives to really push forward the practice of medical toxicology. As described, many of our members only work in toxicology part-time, and they're interested in the society of kind of pushing the envelope and leading the members to have a greater array of opportunities going forward, which is a tall order. It's not so easy. A lot of challenges, as was described yesterday, but something that we feel passionate about in terms of moving forward with the field of medical toxicology. And these were some of the milestones that we met over the last several years with a new billing code and with the development of a series of metrics for medical toxicology practice. And as I also described yesterday, really trying to embrace addiction medicine, very important. I look at other fields that really embrace new technologies or new approaches, and the addiction opioid epidemic in the U.S. has provided an opportunity and a lot of attention to the care of the substance use disorder patient, and a lot of potential opportunities and bridges to build. And one of the things that struck me as we've started to develop partnerships is many of our colleagues on the addiction medicine side really have never even heard of medical toxicology. They may have heard of poison centers a touch, but in terms of a specialty field in medical toxicology, many of the leadership of these other organizations didn't even know medical toxicology existed as a specialty, which kind of redoubles our effort to make ourselves known, to build bridges and develop partnerships, particularly in areas where we have a common interest. I also mentioned yesterday our Toxic Research Network, and this is the program that probably engages the most members. I mean, we have, as the map displays, about 40 sites across the country, and these sites, see patients at the bedside. They're entering cases into our toxic registry database. We have about 80,000 cases at this point, and because of I think the quality of the data and the fact that it's widely distributed across the U.S., we're starting to attract funding interest from partners that are interested in poisoning and drug adverse effect surveillance, such as the U.S. FDA and CDC. So this is an ongoing process. It's been a labor of love. We started with absolutely no funding at the outset 10 years ago, and we're actually celebrating our 10th anniversary on this program. And it's something that can easily lead to international collaborations. And initially, we tried to invite several international partners to participate as sites, and we've had some bit of traction. But I'd like to re-extend the invitation to anyone in this audience who has a toxicology service who's practicing at the bedside, you can participate in our program. You can enter cases and then subsequently utilize the data that's collected as a research database and do studies and investigations. I think this is really important. We've done it kind of low tech just because we haven't had a lot of funding in terms of having a very sophisticated system, but because it's web-based, it's easy to enter cases. It's really an opportunity to collaborate across countries, across cultures, and different healthcare delivery systems. So I'd be glad to speak at more depth at some point about the toxic program, but my dream from the get-go was to really make this universal and across not only the U.S., but across our partners from the 5 continents in terms of participating together and building this together. It doesn't take quite the resources of developing a local poison center might, and something that's, I think, potentially lower hanging fruit to engage others in a collaborative way internationally. And this was our paper that we put out in terms of our annual report. We have an extensive CV, which you can find on the website, or you can do a lit search, and we publish a report each year in terms of what's going on with the toxic program beyond our research papers. And this is some of the citations that you can find on our website. Now, moving into some other areas, public health is an important component of medical toxicology, and ACMT has had the opportunity over the last 20 years or so to engage with public health partners, particularly in the U.S. For a number of years, we had a partnership with the Agency for Disease, the ATSDR, Agency for Toxic Substances Disease Registry. Actually, Dr. Kilborn was one of our big supporters in terms of developing the relationship with ATSDR and the National Center for Environmental Health, which is the CDC component interested in environmental health. More recently, we ran during that period of time, we developed this course on chemical agents of opportunity, which is a course I believe has been given at some of the Metatox conferences in the past. We've given it over 100 times. We recently, with Dr. Bala, did this in India with Dr. Kazi and Dr. McKay as well, and hope to do it in other international arenas as well. It remains a very timely course. We developed it in 2003, soon after 9/11, but the issues regarding chemical threat agents remain today, and the education is equally important. And in this case, this course is designed not just for physicians, but for pre-hospital care providers, for public health providers, and other sorts of health providers that may interface with those sorts of challenges. Since from 2014 to 2019, we ran this pediatric environmental health program in the U.S. This was a multi-million-dollar program. We had the opportunity to run under ATSDR and to partner with the American Academy of Pediatrics, bringing both education and consultation to folks around the U.S. on pediatric environmental health problems. And it remains a very important program. We're currently a subcontractor with the American Academy of Pediatrics, moving forward and maintaining both the website as well as developing online teaching modules. And this is part of the classroom. This is free to anyone to peruse. You don't have to be a member. This is a resource that was developed with U.S. taxpayer dollars. And we have a large number of teaching modules about many different aspects of pediatric environmental health. And I welcome people to visit the classroom, which you can access through the ACMT website and take some of these training modules. That's the purpose of them, is to provide this sort of education. One of the activities we worked on is developing this tool for obstetricians known as the PAIR tool. It's to provide both guidance and an approach to taking the intake history from a pregnant patient regarding environmental exposures. And Dr. Charles McKay actually led this program, which is not yet out as a live program. It's been kind of in the kind of caught up in some of the bureaucracy with the federal government because it was funded by the U.S. Government, but hopefully it will soon be out. And it's a tool that really anyone could use. Developing partnerships between medical toxicology and pediatrics and obstetrics has really been an important component, and I think it's been quite valuable and very rewarding to develop those sorts of partnerships. As I briefly mentioned yesterday, with the opioid epidemic, this is certainly a place that medical toxicology has to be front and center, and we're dwarfed by other much larger groups, whether it be addiction medicine or even emergency medicine, that has much more capacity, and some of these partner groups really hadn't even been aware that medical toxicology was on the scene. So we've started to develop partnerships, we've gotten funding, we've developed position statements and try to be very proactive in terms of our contributions to this field, both from a clinical standpoint as well, in this case, from an environmental and an occupational standpoint. So at that point, I quickly ran through a lot of work that ACMT has been doing. I think our potential growth in the future was continuing to build partnerships, developing funding mechanisms to support medical toxicology. Despite the growth of our membership is really small. The dues only account for about 8% of our total operating costs. So to get the word out, to develop these partnerships for other folks to hear that medical toxicology exists as a specialty requires an investment, and we build these partnerships as a means to that end, to develop the right infrastructure to make a mark and leave a more of a consequential impact on society. Thank you.
Thank you, Dr. Paul, for nice presentation. Have you any question or comment? Later? Okay. Later.
Okay, thank you so much. We will have a question and answer section at the end for the audience to ask our experts. I'd like to introduce our next expert, and this is Dr. David Lenott, who is a clinical toxicologist, and he runs the toxicology consulting service at Hospital IRCCS Mangieri, and he is at the Institute of Clinical Science in Pavia, Italy. It is our pleasure to welcome you, Doctor. Thank you.
Thank you for the nice introduction. And I would like, first of all, to thank Professor Ziad Katsi that inviting me and the society to describe our activity. And a big thank to Bruno Megarban that hard work inside our society and his important role in as bridge for the international collaboration and other societies in emergency medicine, intensive care unit, and a big thank. A thank also for to be here, and I bring you the greetings from the President, Martin Wilkes, and President-elect Horst Thiermann, and from all the executive and board members. I'm very happy to be here as General Secretary of the Society, and we start with my talk, and we talk about the poison center activities, and the poison centers were developed specifically to provide advice to the clinical and public health, but the primary mission of the poison centers has always been an improvement of the poisoned patient, and we are here to do this. And in 1964, Professor Louis Roche and several other visionaries founded the European Association of Poison Center and Clinical Toxicologists with the goal of improving the care of the poisoned patient. And this is the first Congress in Tours in 1964. And the topic of the Congress were the intoxication of the mushroom poisoning intoxication and the intoxication par le fongicide. And the last topic of the Congress was the importance of the network between the poison centers facilities. And this is important also today. And in 1992, Istanbul hosted one of the congress, an important congress of the APCCT, and we discussed the development and controversies in antidote therapy, intensive care and clinical toxicology, hyperbaric oxy in clinical toxicology, and other topic. And I think that it is important to remember that these topics are a problem also today, because we can discuss also for single point also today. And in clinical toxicology, much more needs to be done to improve the patient care. And last year, I'm very proud for this, Italy hosted in Naples Congress in clinical toxicology of our society, and one of the round tables was around in the antidote treatment in clinical toxicology. And we are searching for future location of the Congress. Istanbul may be a future location for our Congress in the future. We are searching for this, and we are open for.
Very nice. Very nice. We will be contact. Yes.
Okay.
We can finish now.
Okay. Okay. And only 47% of WHO member states had a poison control center, and the situation in Europe is this. We have 77 poison center facilities in 33 countries. In some countries, we have only one poison center, and in other 2 or more than 2. For example, in Italy, in Germany, France, UK, after Brexit, and in Poland, for example. And we count now 270 members. And the main activity of our society is organize an annual scientific congress, participate to international projects concerned with position statement and clinical guidelines, promote training, and contribute to European initiative and chemical regulation and cross-border chemical health treat. Okay, but in Europe, the activity of different poison centers differs also for organization, poison center facilities, additional work, poison control center staff. And we need to harmonize and to find a standardization of this activity. And since 1980, our society work on this and to develop a recommendation for a standardized documentation of case data collection in poison center. And in 1997, published in Clinical Toxicology, that is our official journal, the poisoning severity score that is always used to evaluate the severity of the poisonous patient also today. And this is the first document in 2001 about the self-assessment checklist for minimum and optimum standards, quality and accreditation of poison center. This document is now under revision. And another important document that is under revision is the guideline for poison control center, and our members participate in this working group, and many members of EAPCCT are in this group. Another goal of our society is about the classification, labeling, and packaging. In 2 years ago, in particular, 2 members of our society, Peter Breckelmans and Ronald de Groot, publish and include in a European document details about the regulation, and in particular about the Article 45 in CLP regulation in Europe and around the world. Another point is this: members of our society participate to the pool of experts in a scientific committee of health, environmental, and emergency risk inside the European Commission. And in November, last year in November, we participated and described the activity of our society in this field. EPCCT regularly organizes joint meeting with the European Commission, WHO, and particularly through the auspices of the International Programme on Chemical Safety. Now this is an important point because the scientific activity should be spread around the world and in scientific community. And this is the journal of Clinical Toxicology. Clinical Toxicology is our official journal that reached 4.398 impact factor and increase constantly. And there is an important work inside the editorial board, associated editors, and scientific activity inside this paper. This paper is free for online version for our members, for example, and favorable condition for the paper copies of this journal. And between and together with other society, in particular with the AACT, starting from 1999, we published a position statement in gastric lavage, in ipecacuanha syrup use, whole body irrigation, single or multiple activated charcoal administration, urine alkalinization, and gastrointestinal decontamination. Some of these are updated in very recently, and we are working now. There is a group of experts that are working on activated charcoal. This is ongoing, and in QT prolongation in poisoning and in poisoned patient. These papers are ongoing, and we think that will be published in 2 years. We hope. Then I will go to the conclusion, and inside the European Association activity, our members are involved also in survey, for example, in poisonings, rare poisoning, with the aim to harmonize the management around Europe and the world. This is an example for botulism management in Europe. And here are summarized our sister society. We work together with the American College of Medical Toxicology, the AACT, the American Association of Poison Control Center, and the Asian Pacific Association of Medical Toxicology. And we participate regularly to International Congress, UTOX, SOT, Eurotox, and Menatox, and thank you, and EUSEM. There is in this room Kurt Ansju, that is our reference inside the EUSEM Society for Toxicology aspect. Thank you very much. And only 2 slides. Thank you very much to Kurt. We have another way to spread information. We have the APCCT newsletter, Twitter account, and we have a social media working group for this. And we have our website that we use constantly to for the connection with the members, but also for urgent message, for example, because we have, if we use, for example, this forum open to our members, for example, for outbreaks in for example, in some countries involving synthetic cannabinoids, for example, or the recent problem about e-cigarette and pulmonary toxicity, okay? We conclude with this word of our dear members, Professor Hans Persson, that in 1992 in Istanbul, talk about EIPCCT activity, and the word of Professor Persson are very important because inside the comment of our member, the word family comes into the mind. Having attended this Congress for 2 decades now, more than half of the participants are familiar. We are a family, and we need of contribution of all experts in clinical toxicology. And is the important occasion to invite you to join us in Tallinn in May for our annual Congress, and we can find all the information to our website. Thank you very much.
Thank you. So we are going to move on now to our third speaker, who is well known to Meenatox, Dr. Ashish Bala. He is a member of the Asia Pacific Association of Medical Toxicology, which our last speaker referred to, and he is also a professor of medicine at the Chandigarh Institute University in India. Thank you, Dr. Bala.
Thank you, Ziad, for giving me the opportunity to come here again. And one of my friends asked me, why Meenatox? And my response was, I know practically everyone who's trained with Ziad over the years, because I go and I meet them in Atlanta. And this gives me an opportunity to make networking again. So I bring greetings from India, and I bring greetings from Asia Pacific Association of Medical Toxicology, which the previous speaker just referred to. I was asked to talk about what is our contribution. Now, Asia Pacific Association of Medical Toxicology is kind of a very recent organization, a very small organization. I didn't realize till last year that it's been 30 years that we've been into existence when I took over as a president. And at that time, we kind of discussed and we've dwelled into the history. 8 or 10 members from Sri Lanka, India, Australia, Switzerland, London, from WHO. They came together to form a group of interested people in clinical toxicology. And they were all from varied backgrounds, from environmental toxicology to forensic toxicology in Sri Lanka. And they got together, they deliberated, and after a couple of years, they didn't find any worthy, interested people who wanted to take over. The association went defunct for a long time, till the time SACTRAC, that South Asian Collaboration in Toxicology Research, driven by Andrew Dawson, Nick Buckley, Michael Edelston, and like-minded people, came to Sri Lanka. They revived Asia Pacific Association of Toxicology, along with C.C. Yang. People who are toxicologists would know him. Colleagues from Taiwan, colleagues from Thailand, from India, Professor Surjit Singh, who was my mentor. And then they revived this. The idea was to discuss the problems which are unique to the Southeast Asian region, not seen by the Americans, not seen by the Europeans. but seen by us. So we have now members from China, a large group, a very large group from Iran, a very large group from India, a huge group from Australia. But there are very many Asian countries which are not there. We have nobody from Pakistan, nobody from Afghanistan, nobody from South Korea, nobody from Japan. They are just not there. And we don't know what's going on there. So what have we done in last so many years as Asia Pacific Association of Medical Toxicology? We've tried to bring like-minded people together. And mind you, not everyone is a trained toxicologist, like me. I'm an internist who's worked in emergency for nearly 20 years, but then got interested very early in my life in clinical toxicology. 6 years ago, went to London, trained with Paul and David Wood, came back. And I can't forget Paul's line when I wrote to him that I want to come and train with you. He says, what am I going to teach you? Because all we see is paracetamol and club drugs, which is not a major issue in India. What you see there is OP, aluminium phosphide snakebite. We don't see that. So what am I going to train you in? That's where the thought of having a unified kind of a training curriculum for Southeast Asian countries came in. Because David would also, and Bruno would vouch for that. What you see is entirely different. Ziad would remember. He asked me, well, he was teaching me OP poisoning in hazmat course, and I asked him how many cases has he seen. He said, I've treated personally 3 cases. I said, there are times in an hour, I'll get 3 cases in my ER, in 1 hour, right? But he was the instructor for hazmat course, which is an American course. Remember, I won't name the teacher from America who came to teach us about snakebite. And he had no idea of Indian snakes. He's never seen an Indian snake. David Warren came to Chennai, and he saw his first case of a cobra bite there. So what we see is something very different. And what we have achieved is that we have built bridges. We have, as Asia Pacific Association of Medical Toxicology, built bridges with AACT. We have a symposium in their conference. They have a symposium in our conference, and we discuss, exchange our research. Similarly, we have exchange symposium with EAPCCT. Minotox, I'm always there with them, and we are in the process of signing a memorandum of understanding with Minotox, which would give the trained toxicologists from MENA region to come to Asia Pacific meetings and exchange the research ideas. But our problem is we are just around 230 odd members. Not a very large organization. A single conference. And the major problem is resources, money crunch. Nobody is interested in toxicology. Nobody is interested in funding toxicology. So that's where everyone goes to emergency medicine. You know, get lots of money there, not toxicology. And we do not even have very significant regional representative Toxicology Society, which would, kind of feed the original Asia-Pacific meeting. So that's the problem. We have collaborated with EAPCCT, AACT, and ACMT, sending our representatives from Asia-Pacific to work in the projects which David just mentioned. Some of our members are there actively participating in the activated charcoal project. Tanjira is there. So I participated in Extrip 1 along with a couple of my other colleagues. Now Hussein is there representing the Iranian Society, and Darren Roberts is representing the Asia Pacific Association, and we're working with Extrip 2 now to kind of... So what is the way forward for us in Asia Pacific Association of Medical Toxicology? So I was just sitting down and thinking, and last time at the ACMT meeting, when we discussed the toxicology training symposium, and I was there, Badaria was there, and David Wood was there, realized that different from the Americans, we have, or nobody has, a structured toxicology training program. There are no structured toxicology training exit exams or board certification anywhere. I was talking to colleagues in MENA region. They are also facing the similar kind of problem. So I think one of the priorities with us at Asia Pacific would be to sit down with the stakeholders and develop a uniform but regionally modifiable tox curriculum, and decide that how are we going to train our toxicologists. The best trainer is not me. The best trainer is the patient. So you have to go to the bedside, sit with the patient, learn from him, manage him. Only then you'll become a good clinical toxicologist. Short of that, you will become a toxicologist, but you can't call yourself a clinical toxicologist. So unless you've been there on the bedside, managing a patient, you can't be a clinical toxicologist. So that's the way forward. With ACMT, we submitted a proposal to develop a tox curriculum in India. A couple of us got together, 6 university professors, and with Ziad and with Dr. Paul. We submitted a proposal somehow 2 years in a row. We haven't been successful. One day we will be, for sure. We have some regional courses, online courses. There is a SOCTRAC course which is from University of Pasadena, which is an online course. There is a course from University of New South Wales. I think Andrew Dawson and Nick Buckley are managing that course. We have our own Indian course, which is an online course. But it just increases your knowledge base. It does not make you proficient in treating a patient bedside. But gaining knowledge is the first step. Experience would come when you go to the bedside and train. We've started making baby steps, but I think we need to do a lot more. And talking to Antoine Kazi in the afternoon today, I thought of another thing, that we'll need to create 2 different cadres of toxicologists. One, specialist toxicologist, clinical toxicologist, who would be trained in taking care of the patient, doing research, developing guidelines, and then the general practitioners who would have a short-term training in taking care of an acutely ill poisoned patient, at least providing the basics, sending them or feeding them to the specialist toxicology units. For a long time, India only had a single poison center. Now we have 5, and that's the problem with most of the Southeast Asian countries, except for Australia, that we have a single or maybe maximum 2 poison centers. Some of the countries do not have a poison center at all. Many of the countries do not even make their own antidotes, antivenom, for example. Bangladesh, Nepal, Sri Lanka used to depend on India to get their antivenoms. But they have different snakes. Sri Lanka has taken a lead. They have started developing their own antivenom, but many other countries, a lot of need for that kind of development. So I think, in short, this is what we have achieved, but there's a long way to go. A long way to go, plenty of things which we can learn from our European, from our American colleagues, and partner with them and learn from your experiences so that we don't end up making the same mistakes. And we are probably a little wiser than that. Thank you very much.
Thank you so much. It is now my immense pleasure to introduce my colleague and friend, the founding member of Menatox, a member and fellow of the American College of Medical Toxicology, the current president of Menatox, and assistant professor of emergency medicine at Emory University, as well as the founder and director of the Toxicology Fellowship at Emory University. Everybody's favorite toxicologist, Ziad Kazi.
Thank you. Thank you. So I have some slides, a few slides. I'm going to try to finish this quickly, but I want to just hit some points that we heard today. It's clear to me that toxicology development around the world is not complete, and there's a long way to go for most of the world that we discussed today. Menatox is an opportunity for us to do that in our region, learning from the Europeans, from the Americans, from the Asia-Pacific region. So we have many models we can emulate or adapt. So what are we focusing on here in our region? Menatox is focused on several important problems that we are facing, learning from your successes and failures and challenges. First of all, we have a good number of physician toxicologists. We have about 30 to 40 that are in the MENA region, excluding Turkey because we don't have the data for Turkey completely. But these about 40 physician toxicologists, we would like to eventually have proper certification for them, a board certification sponsored by the Arab Board of Emergency Medicine. So this is an important goal that we are working on. We started already the discussion with the Arab Board of Emergency Medicine, and we are meeting in the next couple of weeks to submit a request to look at that. We have one fellowship training in Qatar right now. We need more. And when you have these fellowship trainings, then you will have the curriculum, and then you will have the board certification. So that's an immediate goal that I think we're going to be working on. Our poison centers need some standardization, and we need more poison centers, of course, but the ones that we have need to be standardized. We have several examples we can learn from. It'd be nice to have some data sharing and data reporting. We need to grab the opportunity that WHO is looking at poisonings right now. And I remember when I was a emergency medicine resident or a fellow in toxicology, WHO was not as interested in this field. It was really the sustained development goals and the international health regulations that put us in the forefront of their attention. So we have a period of maybe 10, 15 years that we need to utilize. So Menatox is working on helping individual countries in our region in improving their poison centers and forming their poison centers. And we've done that in Oman through the national poisoning management guidelines and through technical consultation. So we are willing to provide technical consultation to any Ministry of Health in the region that has requests for support in terms of forming a poison center, creating a data collection tool, performing chemical surveillance. And we have done some of these projects in Lebanon, in Oman, and as well as in the United Arab Emirates. So these are some of the activities that we've done. As far as education, we realized that we have to train our own toxicologists even further to provide continuous development for them, which is why we have MinaTox, which I'm trying to really continue to grow with the help of my colleagues on the board, because we have several board members that you have seen across the conference, and you'll see them again the next couple of days. And we're keen on having education for our toxicologists. It's nice to have our own meeting in our own region. It's also nice to go to the EAPCT meeting or APMT or ACMT, but it's nice to have our own meeting. We also want to train emergency physicians and students and residents, and we're doing that as well through our online webinars, as well as through these conferences that actually are kind of multidisciplinary. We have toxicologists as well as other type of specialists. Finally, we're trying to get some research publications, and we started publishing our abstracts last year in the Journal of Emergency Medicine, and this year in the Mediterranean Journal of Emergency Medicine and Acute Care, which is our official journal for MinaTox. In terms of research grants, we haven't had any grants yet, but we're fortunate to get some contracts. And the contracts we received have been in the area of chemical security. And we have used those contracts to fund some of our meetings and fund some of our participants, particularly in Yemen, Iraq, and Turkey. We've had also participants from India in the past. So we're always trying to broaden the scope of our participant group through this type of funding support. We have a long way to go. Finally, we have a good financial structure. We have a bookkeeper, we have a lawyer, we have a website and a webmaster. So I think that needs some more resources, but those are essential. I've learned a lot from being on the board of ACMT, the importance of these type of administrative resources, because without these, you're unable to really act in a professional way and be effective in your outreach. Our membership categories include, your full voting member. We also have the resident member. We have an international membership that we are going to start, and as well as an affiliate membership. And the good news is, I'm going to stop being president in the near future. We are going to have elections, finally. I've been kind of like one of those, dictators presiding over MinaTox, but I think it's time for me to, pass the torch. I think we are going to have an election in the next few months. We already have several people who are running for various positions, including the board and president-elect and the executive board. With that, I want to just leave a few minutes for some comments. Dr. Moreno, is that okay? Dr. Jander? I know we're behind a little bit, but that's all I have to say. Again, I thank you for being here. And if we have some time for questions, we'd love to entertain them.
Thank you very much, Dr. Kazi. Emergency medicine, I say again, but like Dr. from, we need for this motivation, because for the development of toxicology in emergency department or in medicine, first you need bed for patient. You need department for follow the patient. You should intend only you can do this academic position. You should follow the patient, and for that you need critical care unit. You need department. You need bed. And second, for the toxicologists, we need motivation, because you have in polyclinic, for example, if your price or your salary half of the another doctors, anybody don't want to be toxicologist. This is very big problem for development of toxicology in the all, I think. For that, we recommend for clinical toxicology as EPAT. We give very important to toxicology, but we advise to member, for that, first you should build your department for toxicology. For example, 10 years ago, I opened the first toxicology intensive care unit and 4th toxicology unit in Konya in my department. In this unit, only we follow this patient, only for toxicology patient. This is very big experience for us, but if you don't have that and you can't decide how to manage this patient. It's very important.
Right. You're right.
Yes.
I think Dr. Wax mentioned some points yesterday about the practice challenges. Do you want to mention them again, or would you like me to do that?
Into these presentations and noticing all the similarities and the growth challenges that we all confront regardless of where we're from. And I think the driving force is one's passion for the field of toxicology and interest, and in no cases is going to be handed to us. There's really no easy route forward. So I think one has to kind of rely back on their passion and their interests and kind of paving out the right map, whether it's, developing, some sort of more formalized, training approach or, certification. I look back in the U.S. way back in the 1970s when, there was no funding and there was a group of toxicologists that, just put together their own examination and it wasn't recognized by anyone, but it kind of got a start, got their foot in the door, and that ultimately led to, greater recognition down the line. But they kind of, move things forward, and now as multiple societies have done, winning recognition by other partners, governmental partners and folks in allied fields, in the end to move forward, one has to think seriously about how to sustain these partners and leverage one's content expertise for hopefully for funding to support one's members and the society so they can go to the next level. It's a tremendous amount of work. But I think we share so many similarities here, and I think we should also leverage what others have learned, so you don't have to necessarily reinvent the wheel, whether it's curriculum or training programs or other ways of getting in the front door. I think we can all learn from one another.
Thank you, Dr. Wax. I think we need to stop this session because we need to turn the room around. So thank you again. Enjoy a 10-minute break, 10, 15-minute break until we resume. Thank you.
Get going. Introduce him, I assume he's... Just introduce the first speaker?
I will introduce.
Yeah,
I have the point for him. You have to stop, but I don't know where he is. Okay. Hello. I would like to introduce our first speaker for today, Dr. Mustafa Sabak. So Dr. Mustafa is working in a state hospital in Gaziantep as an emergency physician. He is showing interest in toxicology and ultrasound. He is a member of EPAT and ACEP. Also, he is in charge of ACEP liaison in Turkey. He will give us a talk about sedation of agitated patients, agitated poisoned patients.
Hi everyone, Dr. Mustafa Sabak. Unfortunately, I'm not a toxicologist, but I do work in Gaziantep as a physician, and so I have a different perspective of on the same patient population we will discuss. And I'm honored to be here today to be distinguished group of participants and speakers, and I'm very happy today to talk about the sedation of agitated poison patient. And it's responsibility of emergency clinicians to assess and manage this kind of patients properly and without biases and with the same thoroughness that you assess every patient with. And these patients can present challenge that, to you as a clinicians and the colleagues that you work with and to the whole emergency department. And these patients also have high morbidity and mortality and even can present with a high risk of medical legal issue for their behavior. So I have no financial disclosure to report. Objectives of overview of agitation and causes of agitation and quantifying agitation level and some sort of sedation techniques. And I'm going to mention about literature on agitation management and some complications. And agitation is not a diagnosis, but rather a symptom with a variety of potential life-threatening etiologies. And it is an episodic state of intense anxiety, heightened arousal, and increased motor activity. And it's distinctive condition in which things come together and bring about the significant disturbance for their patient's behavior and ability to interact a meaningful way with the environment and the people around them. Why is the patient agitations? There are lots of things that we have to concern about it. It can stem from a multitude of potentials, including head injury, substance abuse, and intoxication. This is important for today. An underlying mental illness, hypoxia, and even manipulation. And metabolic disturbance like metabolic acidosis and hypoglycemia, hypothermia, hyperthermia, seizures like subarachnoid hemorrhage, stuff like that. And these behaviors should be prioritized and promptly to evaluate with the same urgency as the other high risk of patients. But the most important thing is that we have to figure out what's going on about the patients. We see very broad spectrum of agitated patients in the ED, and so we need to categorize them to determine managing procedures. And for this reason, several validated scoring scales can be used to describe the severity of patients' agitations and help predict the risk for violence. And such measures should, can be used to justify clinic decisions, like, for instance, if you want to manage these patients, and we will discuss it later, and for verbal de-escalation or physical restraint, this is a clinical decision for us and help emergency clinicians communicate with the other healthcare providers. This is one of the scales, is very easy, simplest case, and has good inter-rater reliability. And it does not require answer to questions from the patients. And for instance, the score 4 indicates a normal. It's kind of calm state. But patients rapidly escalate from 5 to 7, which is really a serious condition, combative and violent behavior. I'm going to show a short, brief video about this. Sorry. What is the problem? At this kind of severity, agitated patients, we call it excited delirium syndrome. This is a life-threatening medical emergency and underlying psychiatric illness, and often with concomitant drug and alcohol abuse. And wildly adrenergic and remarkably stimulated, strong, and you can see the 4 or 5 police officers couldn't manage the patient, and combative, unable to maintain attention, tachypneic, diaphoretic, and acidotic patients. Why do we sedate them? Because we have to prevent the patient and prevent the other patients, to caregivers and other staff, to avoid serious disruptions and damage to the environment. And we have to evaluate the patient and management patient. We have 3 types of sedation techniques. One of them, verbal techniques. And words can be used to powerful effect to combat the patients while you manage and investigate the causes, the clinicians must engage the patient and establish a collaborative relationship, and the clinician must verbally de-escalate the situation, and only one person should attempt the initial de-escalation, and measures should be taken to ensure process is safe. We have to respect the patient's space, specifically body language and tone of voice are really important for establishing a good communication with the patient. When appropriate, if you have enough situation and available situation, you can give some simple gesture like giving pillow, blanket, or some foods. It's hard in Turkey, I know. For instance, sandwich, it's easy way in the United States. They can offer a sandwich and some juice, but do not give any tea or coffee because it's hot, and the patient can use it as a weapon to you. This dangerous situation could be. And patient should understand which behaviors are acceptable and which will not be tolerated by yourself. If you're not sure where to start, then you can use this SAVE mnemonic. Support, let's work together. You can say to the patients and acknowledge, I see this has been hard for you. And validate, I will probably be same reaction if I were you. And emotion naming, you seem upset, and like this situation. If you don't remember where to start, you can use the SAVE mnemonic for the verbal techniques. If it doesn't work and you try the less restrictive measures have failed, then medical centers of medical care or Medicaid services support the use of seclusion and restraint for the patients. You tried verbal de-escalation, it doesn't work, then give a final chance to the patients, then show the force. But there are some important things if you want to do physical restraints. It's kind of the protocol for the hospital. The physicians should not take a part of physical restraint to the patient. It is hard in Turkey because we don't have enough staff to manage this kind of patients in the emergency department. And required 6 trained staff. And do not attempt physical restraint if you don't have enough inadequate staff available. 1 person for each limb. One of them above the, one of them arm above, and another one below the knee. And 1 person has to control the head, and another person has to administer preparate medications. And do not press their neck or chest because can cause asphyxia. And do not do hobble restraints, which means tying hands and legs backside of the patients, and explains to patients what's going on every time. And physical restraint should always be followed up with chemical and mechanical restraint, and you can remove it easily, and always check neurovascular injury if there is or no. You have to put the patient's supine position and elevate the head roughly 30 degrees to protect aspiration risk, and no need to use pillow, and perform cycle limb release. And you have to make sure the patient's fluid maintains, toileting, you have fully responsible all the things. And this is a good expression by Dr. Billy Mellon. You cannot change someone's personality, but you can obliterate with drugs. So there are some kind of indications for the giving a medication. If the patient is a serious threat to staff or themselves, and you cannot unable to make a decision, and you tried less invasive options like verbal de-escalation, it doesn't work. And for the assessment, intervention, and the treatment. Benzo is one of them. The experts recommended for the undifferentiated agitations for the first-line treatment, for the drug and alcohol intoxication or withdrawal, but we must be careful administrating it to intoxication patients because both benzos and alcohol can cause respiratory depression. Some of the people have died because of this reason, particularly when they haven't been placed on the monitor. And it's more effective than neuroleptics in reducing delirium and mortality and for the seizure. Lorazepam and midazolam are commonly used due to its rapidity of action, effectiveness, but we have to concern about the elimination half-time of it. Midazolam is short of half-time because the per-hospital setting, some of the staff give lots of midazolam or lorazepam, and after that, when the patient get into emergency department, the physician can give more sedative medications, and it can cause respiratory depression. And excessive somnolence and paradoxal disinhibition can cause their adverse events. There are two types of antipsychotics, first generation, which is typical, and the second generation, which is atypical. Antipsychotics for severely violent patients requiring immediate sedation, and for patients with undifferentiated sedation, the experts prefer benzos. If you don't have any benzos, you can use first generation antipsychotics. If you know the patient's mental disease, then you can prefer the antipsychotics. Those are the first generation antipsychotics. Haloperidol and droperidol are used most common to manage acute agitation. But in 2001, droperidol was given a black box, a warning by FDA because of the risk of QT prolongation. It's the same with haloperidol, and haloperidol received a similar warning from the FDA in 2007. Droperidol was given a black box warning the same year as Zofran. So I think the black box warning was probably not based on evidence. I'm not sure, but we can ask our colleagues who work in the United States. But I asked my colleagues who work in the United States, they couldn't find any droperidol. But it's really good drug for managed agitated patients, specifically extremely agitated patients, like excited delirious syndrome. And first generation antipsychotics can cause extrapyramidal side effects and delayed dystonic reaction. Some of them can cause neuroleptic malignant syndrome. Second generation atypical antipsychotics cause fewer extrapyramidal side effects and less sedation than compared to the first generation. Most often in the acute setting, to control severe acute agitation in the ED is limited, but growing and preliminary studies suggest that they can affect the agitation. If the patient willing to take an oral medication, you may give risperidone. It's a good choice for it. Ziprasidone causes the most QT prolongation of any antipsychotic drugs. If you compare the droperidol, the ziprasidone causes the most QT prolongation. There's a combination therapy and with benzos plus first generation antipsychotics. If you want a more rapid sedation and reduce the side effects, it makes sense to use it. And now I'm going to mention about some valuable articles about this topic in this prospective observational study. They compared the 4 agents for the undifferentiated agitation in the ED for mild and moderate agitation. The researchers categorized the suspect cause of patients' agitation into alcohol intoxication, drug intoxication, psychiatric, medical, or combination of the causes. Midazolam more rapid sedation, as was more likely to require additional medications for continued sedation. Olanzapine more effective, and all of the complications rates were low overall and similar across the various medications. In this double-blind randomized trial, they managed agitated patients with droperidol and IV midazolam, and the patient had a mental illness, intox, or both. Their primary outcome were median time of sedation and adequately sedated at 5 to 10 minutes. Midazolam was as effective as droperidol in achieving sedation in 10 minutes, but midazolam group temporarily required assist ventilation and one was intubated, not cause of the droperidol, midazolam. And this double-blind randomized trial, patient treated with midazolam achieved more rapid sedation, but often more rescue medication for breakthrough symptoms, and respiratory depression was very high in midazolam group again. In one of retrospective review, the patients treated by droperidol in the ED, and only 6 serious adverse events were identified, and a single cardiac arrest in patient with a normal QT interval, and it's not clear that droperidol was causative. This is another important article for the droperidol. In a retrospective review, they reviewed roughly 12,000 patients with acute agitation due to alcohol intox. Droperidol given as monotherapy and significantly shortened median length of stay in the ED, which is very important for the emergency physicians, and no cases of sudden cardiac death occurred. In a retrospective review, the primary outcome was the rate of rescue medications in 1 hour. Olanzapine or droperidol were less likely to require rescue medication. But midazolam, if you give the patient midazolam, that means you may need more medication for the patients, and it can cause a more respiratory depression. Several studies suggest that IV olanzapine at doses 5 to 10 milligram may be safe and effective treatment for acute agitation. For the community therapy, their primary outcome was time to sedation, and they researched the need for rescue drugs and adverse events. And combination therapy provided more rapid sedation than midazolam alone, and without an increase in adverse event, and with less need for rescue medication. This is a systematic review of the 7 studies. The outcomes, proportion of patients sedated at 15-10 minutes, and they researched experienced adverse effect and requiring rescue sedation, repeat sedation. Combination therapy resulted in a graded proportion of patients sedated at 15 to 20 minutes, required less repeat sedation. Benzos were associated with a higher incidence of adverse event again. So this article supports the use of combination therapy over alone benzodiazepines use. And ketamine has become a popular alternative for the patients with severe uncontrollable agitation because of fast onset, preservation of airway reflex, and effectiveness via IM administration. The most common dose reported is 4 milligram per kilogram. And ketamine should probably be avoided in older people because the side effects profile is very high. And this is a single study, prospective observational study. Ketamine alone was faster in control of agitation and had a similar rates of redosing, changes in vital signs, and adverse events. In this study, 4 milligram per kilogram IM ketamine, either alone or combination therapy, was used for pre-hospital setting because of its fast, high efficacy rates and low hemodynamic and respiratory side effects. Nearly every patient who was treated with this drug was adequately sedated in average 2 minutes, but significant respiratory depressions occur in 3 subjects. In all 3 cases, had also received midazolam. In this systematic review study, rapid sedation, ketamine provided rapid sedation for the patient with undifferentiated agitation, and however, caution is needed in the hospital setting, given reported high incidence for intubation. And conclusions are very old because they had so many intubation, which could be because the physician in the emergency department, as I told you before, may not know how sedate the patient would become after ketamine. This high intubation rate is not consistent with the other studies. Future options for calming medications in the agitation patients may include inhaled loxapine or IM dexmedetomidine, but strong evidence is pending. I don't know, again, maybe we can ask the expert who works in the United States. Dex is still expensive in the US. I think that's why they rarely use in the emergency department. I don't know, we can ask them. And this is the study for nebulized loxapine case series. All patients were under effect of substance, cocaine, cannabis. The acute agitation was effectively and quickly managed with inhaled loxapine in all poisoned patients. Another thing, expert review, clinical studies have confirmed the efficacy, rapid onset of action, and safety in psychiatric emergency. And that one is an effective and appropriate option for use in emergency setting in patients with acute agitations. For the DEX study, this is 2 cases of amphetamine-induced agitation successfully sedated with it. And that one is 2 asthma cases were reported that they sedated the patient with safety profile and meaningful effect on. And this one, 3 adolescent cases were reported that the researchers controlled the agitation with DEX. So I want to summarize the presentation. The drug and alcohol intoxication or withdrawal are the most common causes. And verbal de-escalation deserve the chance to calm down in response to verbal techniques. And physical restraint, despite the proper approach to combative patients and verbal techniques are unsuccessful. Those are the summarize of the drugs. For the intox, if the patient get the stimulant drug without psychosis, give benzo. If the patient got the stimulant drug with psychosis, give antipsychotic and benzo. If intox with alcohol, give antipsychotic, probably because of the hallucination. And for the psychiatric illness, if there is any psychiatric disorder, give antipsychotic. For the delirium, if the patient on benzo and alcohol withdrawal, give antipsychotic, specifically for the 2nd generation. If you don't know the etiology and the patients don't have any psychosis, give benzo. If the patient has a psycho, give antipsychotic. So we have the drug. Again, I'm gonna mention about this expression. We have the drugs. They have the receptors. Just put two together. Thank you so much.
Okay, we will proceed. The question will be Dr. Aslam is head of Maltepe University, Faculty of Medicine. He is emergency physician at the same university in Istanbul. He has published in both national and international articles and contributed several book chapters. His talk will be about intubation of poisoned patients, when and how.
Hi to everyone. It's always been a hard period of time to talk after the lunch. I hope I complete my speech without boring you. Today I will talk about the intubation of the poisoned. So let's begin. In 2017, American Association of Poison Control Centers released the 35th annual report. This report stated that over 2 million encounters were logged by National Poison Data System, and NPDS documented over 3,000 human exposures resulting in death. According to the same report, serious exposures are increasing by years. Since 2008, less serious exposures tend to decrease by the year 2018. Attention has been drawn to the increase in deaths over the years. In over approximately 30 years, a tenfold increase in deaths is remarkable. The greatest rate of exposure increase since the year 2000 for more severe outcome categories include analgesics, antidepressants, cardiovascular drugs, and sedative hypnotics. This figure shows the increase by the years. Between 2000 and 2013, over 320,000 toxic exposures associated with intubation were reported. The reference is the NPDS 2015 report. In a retrospective review by Bishop et al., published in the Journal of Emergency Medicine 2016, cases managed with endotracheal intubation in the ACMT toxic registry were analyzed. The data were from the American College of Medical Toxicology, Toxicology Investigators Consortium, TOXIC. ACMT TOXIC was established in 2010 and maintains a prospective case registry of all patients managed at the bedside by medical toxicologists in the US, Australia, Canada, Saudi Arabia, and Israel. It publishes annual reports summarizing demographics, source of consultation, agents involved in toxicologic exposures, signs, symptoms, clinical findings, treatments provided, and fatalities. Sedative hypnotics were the most commonly involved, followed by antidepressants and opioids. Multiple substances were involved in 30% of exposures. Both of the top 3 categories of single and multiple exposures consist of the same substances. Central nervous system and respiratory depression were the most common findings in patients managed with intubation. Although there are differences between age groups in pediatric population, CNS medications are in the top 3. Endotracheal intubation requirements can be summarized as airway management, altered mental status, acidosis, electrolyte abnormality, respiratory failure, hemodynamic instability, and seizure. Airway protection need in patients treated with activated charcoal is also another indication for intubation. So simply, intubation need for the poisoned patients is usually the same as and no different from the usual medical conditions. However, there are special circumstances need to be mentioned, such as salicylate poisoning. Let's take a look to a case. A 58-year-old male brought to the emergency medicine because of large dose of aspirin in suicidal gesture. On presentation, he was diaphoretic, tachypneic, and the initial salicylate level was 111 milligram per liter. An arterial blast gas measurement revealed pH of 7.5, a carbon dioxide pressure of 17 millimeters mercury, and a bicarbonate 13 millimole per liter. He was treated with activated charcoal, IV fluids, and IV sodium bicarbonate. Unfortunately, the attending physician noted marked tachypnea and thought that the patient might tire. Consequently, the patient was endotracheal intubated. Immediately after intubation, the patient's pH dropped to 7 and he died 40 minutes later. What a surprise. This case was published in the Annals of Emergency Medicine in 2003 as a letter to the editor. In salicylate poisoning, intubation is a classical point where these patients rapidly deteriorate. Paralyzing patients for rapid seconds intubation leads to a sudden loss of respiratory compensation for the acidosis and the precipitous fall in pH. After the intubation, it is unfortunately too common to reflexively set the vent with a normal rate and a tidal volume. Unless the patient is decompensating, early mechanical ventilation should be avoided. Similar to diabetic ketoacidosis, it is difficult to artificially achieve adequate minute ventilation that sufficiently matches the patient's own respiratory compensation. In addition, the loss of ventilation during the intubation results in rapid loss of respiratory compensation and worsening acidemia. Pesticides have an important place among poisonings that are still problematic. This topic will be discussed by Dr. Agarwal shortly after, so I will be content to touch briefly. Organophosphate toxicity is represented by the sludge or dumbbell syndrome manifested by accumulation of acetylcholine at receptor sites. Pulmonary edema can occur and shouldn't be confused with bronchospasm. Pulmonary edema results from many factors, including the release of inflammatory mediators, cells, and increased vascular permeability. Additionally, pulmonary edema, bronchospasm, bronchoria, and respiratory muscle paralysis all contribute to respiratory failure. Because that is a result of airway and respiratory failure, supportive care should be directed primarily toward airway management, oxygenation, and ventilatory support. Succinylcholine, commonly used paralytic for emergency orotracheal intubation. It is metabolized by cholinesterases and may have a prolonged duration of effect, approximately 6 hours. If succinylcholine is used as a paralytic drug, anticipate the need for prolonged sedation and ventilatory support. But still, a non-depolarizing paralytic drug not metabolized by cholinesterases such as rocuronium is preferable. The next group is the antidepressants. In fact, it's a group of drugs that should be mentioned a lot, but I'd like to say a few words for each group briefly. MAO inhibitors overdoses may result in hyperthermia. Stabilization of the airway, adequate ventilation, and volume repletion are the primary goals. Despite administration of benzodiazepines and external cooling measures may need intubation, ventilation, and chemical paralysis with a non-depolarizing neuromuscular blocker. The use of succinylcholine may incite hyperkalemia if rhabdomyolysis has occurred, and fasciculation from succinylcholine might further increase metabolic heat production. And non-depolarizing agents such as rocuronium should be the first choice. Overdose of SSRIs is usually well tolerated and rarely fatal, with ingestions of up to 30 times the daily dose associated with few or no symptoms. Care of the patient with an SNRI overdose is supportive, with focus on ensuring airway patency and adequate ventilation. Because induction of seizures is common, if needed, RSI should contain benzodiazepines. In severe acute barbiturate intoxication, CNS depression progresses from stupor to deep coma and respiratory arrest. The life threat in severe barbiturate toxicity is respiratory depression. Because respirations can be rapid but shallow, the degree of hypoventilation may not be apparent on clinical examination, and pulse oximetry or capnography may be needed to detect the ventilation compromise. Barbiturates have no specific antidote. The key to managing these patients is supportive care, particularly with respect to the cardiovascular and respiratory systems. Severely intoxicated patients are unable to protect their airway and have decreased ventilatory drive. Long-term induced paralysis are rarely necessary, and additional sedation usually is unnecessary for mechanical ventilation. Most benzodiazepine overdoses follow a relatively benign clinical course. Benzodiazepines produce sedative, hypnotic, anxiolytic, and anticonvulsant effects by enhancing the inhibitory actions of GABA. Binding of a benzodiazepine to a specific benzodiazepine receptor potentiates GABA effects on the chloride channel at the GABA-A receptor, increasing intracellular flux of chloride ions and hyperpolarizing the cell. The net effect is a diminished ability of the nerve cell to initiate an action potential, inhibiting neural transmission. Initial stabilization, including endotracheal intubation, shouldn't be delayed by the administration of an antidote. Most benzodiazepine overdoses can be managed expectantly with supportive care alone. The use of flumazenil as an antidote represents a special feature. Seizures and cardiac dysrhythmias can occur after flumazenil administration, and fatalities have been reported. Flumazenil may cause harm when it is given to patients who have co-ingested seizure-generating drugs, such as cocaine, because of loss of the benzodiazepine's protective anticonvulsant properties. Intubation may be required in such cases. Opioid toxicity can occur as a consequence of intentional overdose or abuse, or as an adverse effect of therapeutic use. Approximately 15,000 Americans die annually due to prescription of opioid overdose. The hallmarks of the opioid toxidrome are CNS and respiratory depression. Respiratory depression is caused by opioids' effect on the medullary respiratory center via suppressing its sensitivity to hypercapnia and overriding the hypoxic drive. When combined with CNS depression, prolonged hypopnea can lead to hypoxia, causing further neurologic complications. Acute lung injury and pulmonary edema can cause a failure of oxygenation. This manifests as desaturations on pulse oximetry, despite an adequate respiratory rate, and rails on lung examination. Patients with acute lung injury may require oxygen and positive pressure modalities such as BPAP, CPAP, or mechanical ventilation with PEEP. If naloxone reverses the symptoms, but the patient later develops recurrent respiratory depression, then repeated naloxone doses, a continuous naloxone infusion, or endotracheal intubation should be considered. I think fentanyl deserves a special part. Also, this topic is fully mentioned in yesterday's course session. The CDC reported fentanyl and fentanyl analogs were the cause of death in more than 50% of the US deaths related to opioids in 2016 and were estimated to be higher for the next years. Like all narcotics, given in sufficient quantity, fentanyl and fentanyl analogs can induce dose-dependent respiratory depression, hypoxia, and death. This figure shows the effects of the potency and the narrow therapeutic window of fentanyl and the most common drugs involved in the US overdose deaths as of 2017. The number of fentanyl and fentanyl analogs related deaths have increased dramatically from approximately 1,000 in 2010 and approximately 3,000 fentanyl related deaths in 2013 to currently over 30,000 deaths. According to European Drug Report, fentanyl does not seem to be a serious problem as in the US yet, but it appears to be in a short time. The rapid increase and high rate in Estonia should be a warning that shows the importance of this issue. Unlike morphine-derived alkaloids, fentanyl and fentanyl analogs can rapidly induce a combination of laryngospasm and severe muscle rigidity in the chest wall and diaphragm at doses within therapeutic range used for analgesia and lower than those doses known to cause severe respiratory depression. Emergency rooms and first response personnel have reported that the normal dose range of the opioid reversal agent naloxone seem inadequate to reverse fentanyl and fentanyl analogs effect, and also difficulty performing chest compressions or ventilation in fentanyl overdose due to chest wall rigidity. Emergency room admissions and survival rate studies of overdoses have shown that the ratios for emergency room visits to deaths are 1-to-1 for fentanyl. Laryngospasm is generally managed in the operating room or emergency room with the administration of muscle paralytics. Without pharmacologic intervention, the glottic structures can remain closed for a period of 15 minutes. Doses as small as 3 mg of 6-phenylcholine can relax the vocal cords without interrupting the mechanical capacity of respiration. However, wooden chest syndrome is treated with full doses of muscle paralytics, followed by endotracheal intubation. Finally, endotracheal intubation remains a cornerstone of early resuscitation of the poisoned patient, but still special circumstances does exist. In patients with salicylate poisoning, intubation should be DRE. The hallmarks of the opioid toxidrome are CNS and respiratory depression, and usually managed with intubation. Fentanyl is a serious problem that resulted in deaths and increased every year. Treatment in complications such as wooden chest syndrome and respiratory depression is neuromuscular blocking agent and intubation. Thanks for your attention and patience.
Thank you very much. I think we'll hold on questions until the end. I'd like to bring up our next speaker, Dr. Bruno Megrban is a long-term member and leader of the Menatox Society. He is professor of critical care medicine at the Paris Diderot University and directs the research team there. He's the head of the Department of Medical and Toxicological Critical Care, a member and leader of the XTRIP working group on extracorporeal poison removal, and he's going to be talking about extracorporeal toxin removal in the poison patient.
Thank you very much, Paul, for this very kind introduction. So we'll talk now about extracorporeal toxin removal in the poison patient. As you know, treatments in medical toxicology are divided in about 0.04%. Then there is a requirement for an elimination enhancement technique by renal extracorporeal support. When such a technique is required, then it should be immediately available within a short time. And of course, generally the patient is in the ICU and it looks like the one at your right hand rather than the one at your left hand. What we'll discuss is unfortunately based only on opinions of experts. There is low evidence data and no randomized prospective study. However, when you have to decide about treatment of a poisoned patient with extracorporeal elimination enhancement technique, your decision should rely on first the knowledge of the technique principles and the drug kinetics, and second, reports from the literature showing that there is some chance to eliminate the toxicant by these techniques with removal kinetics before, during, and after the elimination, and some chance that this elimination will result in an improvement of the patient's situation. These patients who should be treated with these techniques usually have severe poisonings with a drug which elimination could be enhanced, and of course, severe features, failure to respond to full supportive care, impairment of the normal route of elimination, and a relatively good correlation between blood concentrations and symptoms, since all these techniques will only eliminate the toxicant that is present in the blood. First point is hemodialysis is the method of reference to enhance the elimination of the toxicant. What are the chemical characteristics of the toxicants that could be removed by hemodialysis? It should be of relatively low weight, less than 500 daltons, water-soluble, low steric hindrance, poor binding ratio to plasma proteins, less than 60%, small volume of distribution, less than 1 liter per kilo, low endogenous clearance, less than 4 milliliter per minute, and for the best, with a single compartment kinetics. All these properties are difficult to find in internet rapidly or in a textbook, so what is recommended is to calculate the ratio between the percentage of the free drug in the blood and the volume of distribution, and you see that this ratio is lower than 20, then there is no chance to enhance anything by using hemodialysis for your poisoned patient. So, based on these kinetic properties and based on the data providing some benefit in the patient poisoned, there is, to my opinion, 4 toxicants for which dialysis should be considered: salicylate, lithium, toxic alcohols, and metformin. But of course, the list is much more longer for toxicants for which you have or you may discuss the role of hemodialysis case by case. So this is not a closed list, but the 4 toxicants are those where it is mandatory to consider dialysis for the treatment. So we'll consider each of these rapidly. Salicylate poisoning is now getting rarer. Of course, dialysis is the method of choice, and the patients who should be dialyzed are those who are the most severely poisoned, with generally severe features like coma, seizures, non-cardiogenic pulmonary edema, and acute renal failure. They usually present severe acidosis, metabolic acidosis, resistant to correction, and usually you have a contraindication for urine alkalinization due to renal or cardiac insufficiency. Sometimes you have only to rely on the concentration of salicylate, and you see the threshold is 1 gram per liter, measured 6 hours after the ingestion, and this threshold is lower for children or in case of chronic salicylate poisoning. Second indication is lithium. It is much more frequent, about 10,000 cases per year in the US. And you know that lithium is mainly responsible for neurological toxicity. Here you have to distinguish 3 patterns of poisoning. Acute poisoning in a previously untreated patient, acute and chronic poisoning in a previously treated patient who take an overdose, and chronic poisoning in treated patients who develop progressive lithium accumulation due to acute renal failure. Why you have to distinguish these 3 patterns? Because the relation between plasma lithium concentration and the severity of neurological toxicity is different. You see that with acute poisoning, you may have very elevated concentrations but very weak toxicity. With acute and chronic poisoning, you may have less elevated concentrations but more severe toxicity, and with chronic poisoning, almost supratherapeutic concentrations with very severe toxicity. And remember that hemodialysis will only eliminate lithium from the plasma. So this will not modify the lithium in the brain, and with lithium, the problem is the blood-brain barrier. So you can eliminate the lithium from the blood, but you cannot eliminate the lithium from the brain, and this will take time to go out of the brain. Lithium is the perfect toxicant that could be eliminated by dialysis, and this has been demonstrated for a long time based on Albert Jäger's investigations in the 90s, and he showed that half-life could be decreased and clearance enhanced. But you see, and that is interesting, you have a rebound after the stopping of the hemodialysis due to the redistribution of lithium from the erythrocytes to the plasma. Who to dialyze? This is the question. You have to rely on 3 important aspects. First, of course, you have to consider the severity of the poisoning. That means the presence of severe neurological features like coma or seizures. Second, you have to consider the existence of some alterations in renal elimination. And third, of course, you have to consider the concentration of the lithium in the plasma, and you see that this concentration will vary according to the pattern of poisoning. In chronic accumulation, you will have a lower threshold to decide hemodialysis, and in acute overdose, a higher threshold. We reviewed our cases in Paris, in our ICU, and we divided the patients according to 2 parameters, serum creatinine and lithium concentration. And you see that we were able, with a good sensitivity and specificity, to separate the patients according to if they were or not hemodialyzed based on the advices of the physician in charge. And we showed that these 2 criteria seem to be relatively easy to decide to dialyze or not a patient. So if a patient has a concentration of creatinine above 200 micromole per liter or a concentration of lithium above 5.2 millimole per liter, then it's recommended to hemodialyze him. And we were able to demonstrate that in the patients who presented these criteria but who were not dialyzed based on the advice of the physician in charge, it seems in this subgroup that neurological impairments were more important at ICU discharge, despite an ICU stay length of the same length, an ICU stay of the same length. So maybe this is a sort of evidence to support the role of hemodialysis in these patients. The third situation is toxic alcohol poisonings, methanol and ethylene glycol. We talked about that previously. Both alcohols are not toxic, but their metabolites, due to alcohol dehydrogenase, are responsible for metabolic acidosis and organ injuries. Methanol is responsible for blindness mainly, and ethylene glycol for acute renal failure. And here the management is based, of course, on alkalinization, but mainly on the administration of an antidote, ethanol or famotidine, and of course the consideration of intermittent dialysis to remove the toxic metabolites and to shorten the course of hospitalization. The choice of antidote is debatable. In France, famotidine is the first-line antidote to treat toxic alcohol, but if famotidine is unavailable or expensive, you may use ethanol with the same effectiveness. Famotidine has the advantage not to require monitoring of its concentration, and it is devoid of any neurological side effects. So it is easier to use, and in some rare cases it may obviate the need for hemodialysis. So in a number of cases, hemodialysis should be considered, especially if you have severe metabolic acidosis, renal failure, deterioration of neurological situation, or the onset of visual impairments with methanol. Based on the concentration, there is no necessity for absolute hemodialysis with ethylene glycol. So ethylene glycol of more than 50 milligrams per deciliter should not remain an independent criterion for dialysis. However, with methanol, this criteria is debated because, of course, if you dialyze, you may shorten the duration of management in the ICU, and it is possibly cost-effective. So in the US, all the patients with methanol more than 50 milligrams per deciliter are hemodialyzed, while in France we have the chance to be able to spend more money for health problems. We can not dialyze such patients. The fourth situation is metformin poisoning. You know here that this is an increasing situation due to the large prescriptions of metformin in diabetic patients. There are two situations. The first one is acute poisoning, so you will have very elevated metformin concentrations, but a rather better prognosis. And the second is the chronic overdose by metformin due to acute renal failure in a patient who has a comorbidity or an acute morbidity like sepsis or like drug-drug interaction. So here you will have low concentration of metformin, but very bad prognosis. Dialysis is also the treatment. This was established only recently. You see that before 2009, metformin poisoned patients were not dialyzed because metformin has not good parameters suggesting its easy elimination by hemodialysis. Its volume of distribution is very elevated, so that if you want to use hemodialysis, you have to increase the duration, 16 hours of intermittent hemodialysis to eliminate metformin, and you see that the kinetics is in two phases. The first one is relatively quick. You eliminate rapidly the metformin from the plasma, and the second is, you see here, the first one is not working, but the first one is rapid and then very slow because you have to eliminate the metformin from the erythrocytes and from the tissues, and this is slower. So you need 16 hours, and your indications are severe lactic acidosis with acute renal failure and situations with increasing lactate above 5 millimole per liter. And in this situation, you may save, hemodialysis may be life-saving in the majority of the patients. Are there alternatives to hemodialysis? Of course, continuous dialysis and continuous treatments are interesting because they are most more available. They could be suitable in hemodynamically unstable patients. They are easier to use to regulate fluid volume, and they may increase the clearance of mid-molecular weight solutes. However, they have some inconveniences. They have, and the most important one is that they have a lower clearance. So you will eliminate the toxicant more slowly. And the second inconvenience is that you require continuous anticoagulation to avoid the clotting of the extracorporeal circuit and the membrane. So when to use these continuous techniques? In lithium poisoning, it is recommended to use it immediately after hemodialysis. So you hemodialyze the patient during 6 hours, and then to avoid the rebound, you put a continuous hemodialysis. And in this case, as shown here, you have no rebound. In methanol poisoning, especially in case of an outbreak, you will have so many patients who will be referred to the ICU, so hemodialysis devices will not be sufficient to treat all the patients, and this was the case in the Czech Republic methanol outbreak, and patients were treated with continuous hemodialysis. And you see on this slide that, of course, clearance was lower, but the patients were correctly treated, and the condition is to increase to the maximum the blood and dialyzed flow rates to increase the rate of elimination. Are there any additional or any alternatives techniques? Charcoal hemoperfusion. Of course, you may increase the clearance of some toxicants with charcoal, like carbamazepine, phenobarbital, phenytoin, paraquat, theophylline. So there may be some advantages. However, there are major inconveniences. You require greater anticoagulation. The charcoal cartridge are rapidly saturated, so there is a cost for this technique, and the tolerance is very bad. So, to my opinion, don't use charcoal hemoperfusion. What about exchange blood transfusion and plasmapheresis? It's more complicated. It is, of course, not so obvious to think that if you change the blood, then you will eliminate the toxicant, because the toxicant is in the cells, the tissues. But in some very specific situations, like acute and severe hemolysis, intravascular hemolysis with, for instance, methemoglobinemia, it may be appropriate to do exchange blood transfusions. So just exceptionally use these techniques. What about albumin dialysis? It may be interesting to use albumin dialysis to enhance the elimination of toxicants that are linked to albumin. And this is the principle of the Mars system. But the problem is that this technique is very difficult to set up. You require a specialized nurse, and he will require about 3 to 4 hours just to set up the device. So it is very time-consuming, and the benefit till now is not proved. So just use this technique if you want to investigate the ability of this system to increase the enhancement, to increase the clearance of the toxicant. So, as you see, there is no recommendation, and there is no high-level evidence to use or not dialysis, or to use or not such device. So there is an international group, I have the chance to be a part of this, called Extrip, and we met several times, and we made some recommendations regarding the elimination techniques and indications in poisonings, and many of the resulting recommendations are published, and you can find them on PubMed. So in conclusion, for most severely poisoned patients, supportive care and antidotes are all that is necessary. There is no need for anything else and no need for extracorporeal renal support. But in some limited cases, there is an indication. And this indication could be life-saving and is urgent. So in practice, hemodialysis should be considered in severe poisoning with salicylates, lithium, methanol, ethylene glycol, and metformin, and in all other toxicants, it should be discussed at the basis of a case-by-case discussion. And of course, as you understood, further studies, and especially randomized studies, are needed to evaluate the benefit. And further experience is also needed to evaluate the other techniques than hemodialysis, like continuous techniques. Thank you very much.
Thank you very much. That was a wonderful overview. At this point, we'll have the questions at the end of this session, so thank you. And so we'll move on to our final speaker. It's really my delight to introduce Dr. Praveen Agarwal. Praveen is a professor of emergency medicine at the Ames Institute in New Delhi. He's chairman of emergency medicine and one of the leading toxicologists in India, along with Ashish Bala, who you heard from earlier today. And I also had the opportunity to be involved with training Dr. Agarwal many years ago in the States to teach him a little bit about American toxicology, but he's taught me much now about Indian toxicology. And they have a lot of particular expertise, particularly coming to the topic that he's going to be discussing today. And he's going to discuss an update in the management of OP pesticide poison patients in the emergency department.
Thank you, Dr. Paul, for your kind introduction. In fact, as he said, I worked under him in 1999, got training in toxicology at USA. Thank you, Dr. Paul. So I'll be discussing about the management of acute the pesticide poisoning and update in emergency department. So as you know, pesticides are widely used in industries, in the agriculture, in the domestic houses for various purposes. And it's a major problem, the poisoning is a major problem across Asia-Pacific region. Nearly 3 million cases of poisoning occur every year across the globe. And of these, about 200 to 300,000 people die because of pesticide poisoning. Majority of these pesticide poisoning are because of organophosphates. So remember, organophosphates is the major killer across all over the world, but most likely in the Asia-Pacific region. Now this slide just shows the various organophosphates. We have diethyl, dimethyl, and atypical organophosphates. The importance here is that dimethyl organophosphate, when they combine with acetylcholinesterase, they form a complex with the aging of about 3.7 hours. The half-life is about 3.7 hours only. While the diethyl compounds, they form the complex with aging of about 33 hours. So there's a wide window for the diethyl organophosphates in case you want to use pyridoxine. This is just the physiology of various acetylcholine receptors present in the body. And you can see that the receptors are present in the autonomic ganglia, in the postganglionic fibers, in the adrenal glands, in the heart, in the sweat glands, in the gut, in the bladder. All of these can produce various features of acute cholinergic poisoning. This is the mechanism of toxicity of organophosphate. Normally what happens is that when acetylcholine is released into the synaptic cleft, it is metabolized, it is inactivated by acetylcholinesterase to inactive compounds. But when organophosphate is there, it inactivates acetylcholinesterase, resulting in stimulation of the post receptors by acetylcholine, causing various cholinergic features. Now, organophosphate poisoning, there are 3 phases of organophosphate poisoning. The first and the most important for the emergency physician is the acute cholinergic crisis, which occurs in the first few minutes to first few hours of ingestion. The second is the intermediate syndrome, which occurs with some organophosphates about 24 to 96 hours after ingestion. The third is the organophosphate-induced delayed polyneuropathy, which occurs about 2 to 4 weeks after ingestion, which is a sensory motor neuropathy. Generally, these patients won't present to the emergency department. These are the typical clinical features of organophosphate poisoning. We have dumbbells for the muscarinic, but the 3 important are the 3 killer Bs: bronchoria, bradycardia, and bronchospasm, and of course the low blood pressure. The nicotinic ones are the respiratory failure mainly, and the CNS were the confusion, coma, and convulsions. Now, important about organophosphate poisoning is that organophosphate generally dissolved in hydrocarbons. So when somebody ingests organophosphates, the person can aspirate hydrocarbons into the lungs, causing breathing difficulties, can cause ARDS also. These are some of the EC changes which can occur with organophosphate, but important thing is the QT interval prolongation and some ventricular tachycardia, including ventricular fibrillation also. Now, this is the score which we commonly use in our emergency department, Paradynia scores for severity of poisoning, which is based on the clinical features only, the pupillary size, the respiratory rate, the heart rate, presence or absence of fasciculations, the level of consciousness, and the presence or absence of seizures. These are quite good, reliable score for defining severity of organophosphate poisoning. The diagnosis is generally by clinical only. We hardly use the plasma pseudocholinesterase levels or the RBC cholinesterase levels. Now, intermediate syndrome is an important thing for emergency department. The patient may come to us with mild organophosphate poisoning with few features of cholinergic toxicity. You may discharge the patient, but the patient may come back again after about 24 to 96 hours with acute respiratory failure. So that is why patient with organophosphate poisoning should remain in the hospital for at least 96 hours. They should be closely monitored for any respiratory failure, and if required, they should be ventilated by intubating the patient. Now, coming to management of the patient with organophosphate, if there is external exposure to the patient, suppose the patient is exposed to the organophosphate through skin, external decontamination is required. Otherwise, for the injection, the patient should be resuscitated, stabilized, given muscarinic antagonist like atropine, and if indicated, gastric lavage. The role of pralidoxime, the acetylcholine reactivators, is very, very doubtful. We do not use it. And definitely, if the patient does not respond to these therapies, then we need to give some novel therapies to these patients, which I will discuss later on. Now, the only thing about external decontamination is that you must protect yourself when providing the external decontamination. It should not happen that we have one victim of organophosphate poisoning and then we become the second victim of poisoning. So for the initial stabilization, the standard is the ABC for any emergency. But the important thing here is that if the patient comes in cardiac arrest, we start the ACLS protocol, but in addition, we start the atropine therapy also. So remember, atropine is indicated in very few situations in ACLS program. Atropine is removed from the ACLS guidelines now. But if the patient is organophosphate or carbamate toxicity and comes in cardiac arrest, then the patient will require atropine to be given to the patient. Of course, to avoid aspiration, keep the patient in left lateral position, give high flow of oxygen because they are often hypoxic, intubate the patient if the airway is breathing compromised. Now, one of my previous speakers talked about the intubation. Avoid succinylcholine again to re-emphasize it because it also gets metabolized by the pseudocholinesterase. And if we give succinylcholine along with the OP poisoning, the duration of succinylcholine duration will be prolonged to 6 to 12 hours. Now, atropine is the initial drug of choice for patient with organophosphate poisoning. If the patient has meiosis, small pupils, excessive sweating, has bronchoria or bronchoconstriction, has bradycardia and hypotension, the patient requires atropine. But if the patient does not have any of these 5 markers of cholinergic toxicity, then the patient should be still observed for about 12 hours for delayed toxicity. The dose of atropine is 2 milligram intravenously, and it should be given even if oxygen is not available. The dose for children is for about 0.05 milligram per kilogram, the first dose. After 5 minutes of giving atropine, check the 5 markers of cholinergic poisoning. If there is no improvement, double the dose of atropine to 4 milligram and continue to double it every 5 minutes till you get the endpoints. The endpoints will be clear chest on auscultation, heart rate more than 80 beats per minute, that is, there is no bradycardia. The systolic blood pressure is more than 90 millimeter, that is, there is no hypotension. Of course, you can look at the pupil, they should no longer be constricted. There should be no sweating, that is, axilla should be dry. This just shows a schematic diagram for the atropination. Give doubling dose, 2 milligram, 4 milligram, 6 milligram, 8 milligram, 16 milligram, and so on. The important thing is that patients often lose a lot of fluids because of recurrent vomiting, because of urination, because of salivation, because of sweating. So along with atropine, start IV fluids, give about 500 ml to 1000 ml of saline. And also once the patient is atropinized, Start the infusion of atropine at a dose of 10 to 20% of the total dose given initially, that is every hour, and assess the five parameters of cholinergic toxicity every 50 minutes. Make a diagram, like make a chart in your emergency department about the various vitals, monitor them every 15 minutes. The patient may require boluses of atropine in between, or the patient may develop atropine toxicity. Once the patient is stable, reduce the dose of atropine by 20% every 4 hours, so that generally by about 24 to 48 hours, you are able to stop atropine. These patients can also have hyperthermia, so external cooling is also important in this patient. Now, these are the features of atropine toxicity: agitation, confusion, urinary retention, and paralytic ileus. Of these, most important is paralytic ileus. So keep on auscultating the abdomen every 15-20 minutes initially for any signs of atropine toxicity. If the patient develops atropine toxicity, stop infusion of atropine. Wait for about 30 minutes. The signs of toxicity disappear. Start the infusion again at about 75% of the initial infusion rate. Now, this is the one which we often use as the first intervention. Remember, gastric lavage can never be the first intervention in any of the poisonings, particularly for the pesticide poisoning. If you want to do a gastric lavage, it should be done only after the initial resuscitation, the initial dose of atropine, and there also the role of lavage in organophosphate poisoning is very, very doubtful. Again, as I said, it can increase the chances of aspiration pneumonia because organophosphate dissolved in hydrocarbons. Again, activated charcoal, probably no role again. There are studies showing that it probably doesn't act in patients with organophosphate poisoning. Now, do we have any evidence of doubling doses of atropine? We keep on doubling doses every 5 minutes. There are two studies which were conducted, one in Sri Lanka and second in Bangladesh. In the first study done in Sri Lanka, the 3 hospitals were chosen, and there were about 272 patients. In 2 hospitals, they gave doubling doses of atropine, and in the 3rd hospital, the standard routine was given, just the boluses of atropine were given. And what was found was that patients who received doubling doses, they received less of PAM and less of atropine. They also had lower occurrence of atropine toxicity. But there is no difference in mortality or ventilatory rate in both the groups. In contrast to this study from Bangladesh, this study was done in Bangladesh. Again, they divided into 2 groups. There were about 156 patients. And they found that giving the doubling dose of atropine reduced the mortality, reduced time to atropination, reduced the incidence of atropine toxicity, and also reduced the incidence of ventilation. So this study clearly showed that doubling dose of atropine is quite effective in reducing all the parameters associated with organophosphate poisoning. Now, coming to the second antidote, which is pralidoxime. Many physicians still use pralidoxime, and the dose recommended is 30 milligram per kilogram of PAM chloride over 15 to 20 minutes, followed by infusion of 8 to 10 milligram per kilogram per hour. In India, we have mostly PAM iodide, which is less effective compared to PAM chloride. There are several adverse effects associated with the PAM, which include tachycardia, hypertension, muscle rigidity, laryngospasm. Now, let's see whether pralidoxime is really effective or not in patients with organophosphate poisoning. It may be ineffective if there is aging of the organophosphate acetylcholinesterase complex. Also, there is a variation between the different organophosphates. They may or may not respond to pralidoxime. There are no effective protocols in terms of doses which have been established for pralidoxime. In various studies, the dose have varied from 0, that is no PAM was given, to 24 grams a day. It is also not likely to address the non-acetylcholine effects of the organophosphate. Now, organophosphate have many other effects. They can directly affect the tissues. They can directly affect the neuromuscular junctions. So that's why it is not possible that pralidoxime is going to affect all other non-acetylcholine effects of the organophosphates. In addition, in developing countries, we have the problem of cost. It costs about $5 per gram of pralidoxime. And suppose you want to get 24 grams per day, it will become very high cost for us. Now, there are many studies done on comparing various doses of pralidoxime. The first studies were done from India in 2006, reported in 2006, in which 200 patients were included. They were given, one half were given high dose of pralidoxime. The second group was given the normal low dose of pralidoxime. What they found was that in the high dose group, there was less need of atropine during the first 24 hours. There was less need of intubation, and there was lesser duration of mechanical ventilation for the patient who received high dose of pralidoxime. But there was no change in mortality. There was a second study was done from Sri Lanka, which was again a double-blinded placebo-controlled trial of 235 patients. In this study, they found the mortality was higher in pralidoxime group, and the need for intubation was similar in both the groups. There were two meta-analyses published in 2018 and 2019, and both in the first meta-analysis, what they found was there was no significant difference in terms of risk of death, intubation, development of intimate syndrome, complications, and duration of intubation between the patient who received pralidoxime and the patient who did not receive pralidoxime. The second meta-analysis was published in 2019, which again found that the mortality was probably higher in patients who received pralidoxime. So with these two meta-analyses, it is possible probably that pralidoxime should not be given to a patient with organophosphate poisoning. Now, some people do use glycopyrrolate in place of atropine because it controls the secretion better. It produces less of tachycardia. It does not cross blood-brain barrier easily, and therefore will not cause much of confusion or delirium. But the problem with glycopyrrolate is that it is less effective in treating bradycardia induced by organophosphate, and it may not reverse the CNS effects of organophosphates. So most of us may give glycopyrrolate in case the patient is not having much of bradycardia and not having much of CNS effects, but it is costlier than atropine. Now, there are several novel agents which have been used in the past, which include magnesium sulfate, clonidine, sodium bicarbonate, and recombinant bacterial enzymes like butyryl cholinesterase inhibitor, cholinesterase. There are small studies conducted on the use of these novel agents. The first study about magnesium sulfate was on about 45 to 45 patients. One group got 4 gram magnesium sulfate over 24 hours as infusion. The second group did not get any magnesium sulfate. Oxime atropine was used in both the groups. So what was found was, in the magnesium group, none of the 11 patients who received magnesium died. While in the control group of 34 patients, 5 patients died who did not receive magnesium. So probably they concluded that magnesium may be effective in patients with organophosphate poisoning. But there was a study from Iran in the year 2018, which included 80 patients. Again, one group received magnesium sulfate 2 grams every 2 hourly for 3 doses versus saline, and they found there was a reduced duration of admission for patients who received magnesium sulfate. This was a meta-analysis of patients who received magnesium sulfate versus no magnesium sulfate in OP poisoning, and it was found that it probably decreased the mortality if patients were given magnesium sulfate. The second drug would be sodium bicarbonate to alkalinize the blood to a pH of about 7.45 to 7.55. It has several mechanisms of actions, including it increases the OP clearance by hydrolysis, it expands the intravascular volume, it has a direct effect on the neurovascular junction, it has probably effect on the aging of the acetylcholinesterase OP complex, and probably improves the oxime activity also. Again, very small studies are available. This is a study of about 53 patients. One group received sodium bicarbonate, the second group did not receive sodium bicarbonate. So what was found was that total doses of atropine in the control group were higher than the group which received sodium bicarbonate. The admission rates were higher in the control group, that is patients who did not receive sodium bicarbonate, than the test group, that is the patient who received the sodium bicarbonate. Again, this is a very small study. Salbutamol is also being recommended, or at least thought of, as a treatment for patients with organophosphate poisoning. It relieves OP-induced bronchospasm. It increases fluid elimination from the lungs, thereby improving the oxygenation. But the recent study conducted in Bangladesh, which did not show any benefit of use of salbutamol. Now, diazepam is another antidote which is being tried in patients with organophosphate poisoning. In OP poisoning, what happens is there is uncontrolled stimulation of the respiratory center, which causes decreased renin nerve output. Diazepam, what it does is that it attenuates the respiratory system activity, thereby inhibiting the CNS respiratory depression paradoxically. But again, we don't have much of evidence in favor of diazepam. This is a study done in animals, in rats basically, and what they found that if the patient were pre-treated with diazepam before giving dichlorvos, 44% animals or the rats survived at 10 minutes, but none survived at 24 hours. So probably again, diazepam may not be really effective in patients with organophosphate poisoning. Another concept is the use of bioscavengers, like use of cholinesterase enzyme, which sequesters organophosphate compounds in the blood so that the target level, the target concentration of organophosphate is reduced. The second is the use of hydrolysis, which hydrolyze the organophosphate in the blood, thereby reducing the concentration of organophosphate in the blood. And one of them, that is OPDA, has been found to be useful in animals. Now there are 2 or 3 studies on bioscavengers. In the first study, again very small study, 33 patients, 20 received atropine plus PAM, 9 received plasma which contains butyryl cholinesterase, and 2 received plasma after they developed intermediate syndrome. Now what they found was that patients who received only PAM and atropine, the intermediate syndrome developed in 28.8% of the patients, that is 6 out of 21, while in 9 patients who received plasma, in none of them intermediate syndrome developed. There were no deaths in the patient who received plasma, so thereby probably meaning that the plasma, giving plasma to this patient may be effective if the patient has severe organophosphate poisoning. But on the other hand, there was a second study in which they did not find any evidence of any benefit of use of plasma or 20% albumin in patient with organophosphate poisoning. Now, nicotinic receptor antagonists are also being tried because nicotine is one of the receptors at the neuromuscular junction. So if it gives something which is antagonizes the nicotine receptor, it may produce beneficial effect in patient with organophosphate poisoning. So there's a trial in the animals, not animal in the humans, but it's a phase 2 trial where the use of rocuronium has been shown to improve the outcome. But again, the number of patients very small, only phase 2 trial was there. The last one is the second last would be the use of intravenous lipid emulsion. Now it is being used in almost every poisoning. This was a study conducted from Chandigarh. Dr. Ashish Bala is here, who conducted this study. This was a study on 40 patients who were symptomatic because of organophosphate poisoning. But they found that there was no significant change in hemodynamic parameters in patients who received intravenous lipid. Compared to the historical control, there was no change in mortality, but there was some reduction in duration of ventilation and hospital stay. There were no adverse effects. That's an important thing. Now, there is a review of literature from China. About 7 randomized controlled trials were systematically studied. All were reported from China in Chinese literature. And they have studied about 630 patients. So what they found was that intralipid improved the cure rate. It decreases the mortality rate. It decreases the respiratory muscle paralysis when the patient receives intravenous lipid emulsion. So what we require is probably a larger trial on the use of intravenous lipid emulsion in a patient with severe organophosphate poisoning. Now, Dr. Bruno talked about the extracorporeal removal of the toxin. This was a study from Turkey, in which they had 260 patients who were divided into 2 groups. They had severe organophosphate poisoning. All received, at least 40 of them received hemoperfusion within 3 hours of injection, which decreased the mortality, decreased the incidence of intermediate syndrome, and decreased hospital and ICU stay. 44 patients received organ transplantations from these 20 donors, and the outcome was really good. 3 of the recipients died, 3 had graft dysfunction, but 34 had good graft function within first 6 to 12 months. So probably again, we should not declare these patients that they are not fit for organ donation. They can be taken as organ donors. If the kidneys are functioning well, the heart is functioning well, they can be good organ donors for the other patients. So to summarize, what we require is basically a large multi-center trial using these novel drugs, like we have plasma, we have sodium bicarbonate, we have intravenous lipid, Right now, what we have is a single-center studies having very small number of people, patients most often, except for the hemoperfusion study, which has 260 patients. So I would feel that probably we require, as a research, a multicentric group thinking about the various drugs which we can use in patients with organophosphate poisoning. Thank you.
Thank you very much. Really an excellent presentation. At this point, because of time constraints, I think we'll end this session. We're running a few minutes behind, and there is a break right now. So why don't we take a 10-minute break and begin at 4:40 for the final session of the day. Thank you.
Yeah, I'm Hussein from Tehran, and we are working together to moderate this session. And please introduce the first speaker.
All right, we're going to have an abbreviated session in that we have a couple of talks that have been canceled. So our first speaker is going to be Mohammed Al-Malki. Mohammed is a practitioner of both internal medicine and medical toxicology. He did his medical toxicology fellowship with us at Emory University. He is currently also the chairman of internal medicine at this hospital in Riyadh, which is King Saud Medical City. And he's been a board member of Minotox for over 4 years. So we want to thank him for his contributions and looking forward to his next 15 minutes of his talk.
Hello, everyone. So my talk today will be about utility of drug screen in emergency department. So this is the outline of my talk. We'll start by giving you introduction about emergency drug screen methods that we are using for emergency drug screen, including immunoassay and chromatography techniques, limitation of immunoassay techniques, some evidence from the literature about use of drug screen in emergency departments, and then a conclusion. So basically, urine drug screen is a panel of tests that are done on biological samples, and most of the time it's urine, even it can be done on other samples. Then it can give you like a result it will tell you whether a specific drug or even its metabolites are present in that sample or not. Most of these screening tests does not give you quantity. Like they will tell you like if this drug is positive or negative, but they will not give you a specific concentration, despite some newer machines can give you like specific concentrations. So basically, drug screen is a two-step process. Initially, you have to do a screening test using immunoassay, and if that biologic sample tests positive for any drug, this does not mean it's positive. You have to confirm your result using another test. We call it confirmatory test, and different techniques used for that, like liquid and gas chromatography. So basically, like checkpoints at the airport. So initially, biologic sample will be screened to see if any drug is present there or not. If the test is positive, this does not mean it's positive. So you need to confirm your result by doing another test, confirmatory test, using gas and liquid chromatography. So for screening, we are using different machines are available. And most of these machines, they are using immunoassay techniques. They use antigen-antibody interactions. They have specific antibodies against specific classes of drugs or even its metabolites. So if the biologic sample contains that specific drug or even one of its metabolites, then it will give you a positive result. But again, this is not specific test. You have to confirm your result using chromatography. So commercially available immunoassays, they will test for multiple different drugs. The most commonly tested drugs are amphetamines, البarbiturates, البنزودازepines, الcocaine, الopioid, THC, and phencyclidine. Some machines, they will even test for more drugs like tricyclic antidepressant and the others. But these are the most commonly tested drugs. So immunoassay techniques are inexpensive, widely available in the emergency department, and easily automated. It's not sophisticated technique and can give you the results quickly. What is the problem with immunoassay techniques? We have three problems. The first one, these tests are qualitative tests. So they will not give you specific concentration for that drug. They will tell you if the drug is positive or negative, but they will not give you specific concentration. Some newer machines will give like specific concentration, but the majority of immunoassay techniques, only they will tell you if the drug is positive or negative. So the second problem with immunoassay technique is reliability issues. So these are screening tests. So they are highly sensitive. Their sensitivity is very high. So you will have a low false negative results, but they are not specific. Their specificity is low. Also, their negative predictive value is low. So if you have a positive result with the immunoassay, this is not a confirmatory test. You have to do a second step. You have to confirm your result with a more specific and diagnostic test like chromatography. So these diagnostic tests are highly sensitive and specific. The third problem with immunoassay techniques is cross-reactivity. So they have a lot of cross-reactivity with a large list of drugs. For example, if you will eat this meal, you will test an immunoassay positive for opioid. So the poppy seed, they have cross-reactivity with the opioid immunoassay. So if you can see here, like there's interaction between different immunoassays for of different drugs. It's like amphetamines, they have a huge list of interactions. They can give you a false positive result with dextroamphetamine, ephedrine, with MDMA, labetalol. Also, they can give you a positive result with if someone is using ranitidine and the others. So they have cross-reactivity with a large number of drugs. For example, also THC, they have cross-reactivity with non-steroidal anti-inflammatory drugs. They have cross-reactivity with proton pump inhibitors. Opioid also, they have cross-reactivity with poppy seeds. They have cross-reactivity with rifampicin, phencyclidine, and tricyclic antidepressant. Tricyclic antidepressant, they have cross-reactivity with carbamazepine. They have like similar structure, so it can give you a false positive result in someone who is using carbamazepine. And also, they have cross-reactivity with quetiapine. So you can see huge list of drugs that can give you false positive results. So these are not diagnostic tests, only used for screening. So if you would like to confirm your result, you have to use more sophisticated techniques like gas chromatography, liquid chromatography, and mass spectrometry. Confirmatory tests are highly specific and sensitive, but again, they require more trained technician and to perform these tests. And also, you need an expertise to give you interpretation for the results. They can give you quantitative concentrations. It's not like immunoassay techniques for a specific substance or even its metabolites. But again, they are not available everywhere. And you cannot get the results immediately like immunoassay techniques. So, clinical scenarios where emergency drug screen is used in the emergency department. Emergency drug screen has been become like standard of care for a lot of patients. It's frequently ordered in patients who present with a drug overdose to the emergency department. Also, frequently ordered in patients who presented with CNS signs and symptoms, like someone with agitation, altered mental status. It has been frequently ordered. in psychiatric patients who present to the emergency department with psychiatric signs and symptoms like agitation, psychosis, delirium. Also, it has become a standard of care in trauma patients. So it's frequently ordered, but what is the utility of these tests? Do we need it? Does it change the management of these patients and their disposition in the emergency department? So what does the literature say? We have a lot of published articles discussing this issue. Over the past few decades, several articles have been published to address the utility of emergency drug screen. One of the earliest studies that has been published was in 1974. So this was a retrospective trial. 148 patients enrolled in this study, and they concluded that there is no utility for emergency drug screen in the management of patients in the emergency department. Later on, another study has been published in 1987 by Kellerman. This study was a prospective clinical trial, and they enrolled 196 patients in this study. And the main question of this study was how often emergency drug screen will have substantial change in the management of patients in emergency department. And they concluded that only 6 out of 196 patients, there was change in their management. And even 3 of these patients, the change was to discharge home as they have negative results. Sorry, just. What about psychiatric patients presenting with psychiatric signs and symptoms like agitation, delirium? So emergency drug screen has become one of the commonly ordered investigations in these patients. One study has been done in 2000. It was this one was a randomized controlled trial. They enrolled 2 groups of patients in this study. 198 patients enrolled in the urine drug screen versus 194 patients enrolled in the traditional treatment arm. And the question of this study was like if emergency drug screen has an impact on disposition of psychiatric patients in the emergency department. It has been found that there's no change in disposition of psychiatric patients who presented with psychiatric manifestations to emergency department. What about trauma patients? So emergency drug screen has been become one of the standard of care for trauma patients. It's frequently ordered in these patients, and even it has become like one of the requirement to be certified as level 1 and level 2 trauma patients to have available urine drug screen. Multiple studies has been published in the peer-reviewed literature about the utility of urine drug screen in these patients. And all of these studies, they concluded that there is limited utility of routine drug screen in trauma patients. So at the end, the conclusion from the literature review, the literature does not support an emergency drug screen as being helpful in the acute management of patients in the emergency department. Also, it does not change the disposition of these patients. Screening results rarely change clinical management of a patient who presented to the emergency department. What about the clinical guidelines? So a clinical guidelines that has been developed by a UK clinical scientist and toxicologist and by a clinical toxicologist and clinical laboratory scientist, they recommended against the availability of emergency drug screen in the emergency department. Also, a similar guideline has been made by the Alberta Medical Association, and they also make the same recommendation. There is no utility for emergency drug screen in the emergency department. So, conclusion, emergency drug screen is unlikely to significantly impact management of patients in emergency department. Also, it has no impact on disposition of these patients. That's it, I'm done.
All right, we have some time for questions. Then on subsequent follow-up with psychiatry, it may not change their disposition at that time, but that could help the psychiatrist, someone who's an intentional adult, to know that someone has, cocaine use disorder or, marijuana use disorder, and that could help them get targeted to just different treatments that could benefit them.
I did not get across any article discussing if they are useful for follow-up. I have no idea if there's any published article to discuss utility of these emergency drug screen as a follow-up modality in psychiatric patients. I came across studies talking about useful if these urine drug screen are important for disposition in the emergency department in psychiatric patients who presented with psychiatric manifestations like agitation, delirium, etc. But I'm not sure if there are any study about usefulness of these immunoassay as a follow-up modalities.
Okay, thank you. Sure, after we finish with these questions, yeah. Okay.
I have a question, Mohammed. As a physician, I'm wondering what should I do? From tomorrow, I should stop ordering drug screening for my patients?
So,
does it mean that I should follow drug screening by confirmatory tests? Or should I do confirmatory tests from the beginning?
So basically for intoxicated patient, what we need, we mainly depend on clinical signs and symptoms. So you have to rely mainly on your Toxidrome recognition. It can help you, but again, as I told you, if you have, for example, a urine drug screen which tests positive for opioid, this does not mean that your patient was using opioid, because you will have a lot of cross-reactivity, and this test should be confirmed by another confirmatory test, which is sophisticated techniques, not available everywhere, and even you need to need sometimes 1 day or 2 days to have the results. So basically for acute intoxication, you have to depend on your Toxidrome recognition. But they can help, yes, but if you have a positive result, you have to put in your mind that you can have a lot of false positive results, and also a loss of cross-reactivity with other drugs. Like, for example, if someone is using tricyclic antidepressant, it can give you a false positive result with a lot of drugs, as I showed you previously. Amphetamines, they have large list of cross-reactivity. Other questions?
Any other question from the floor?
Okay, thank you.
Let me introduce from Turkey. He is currently working in Ministry of Health as a director of the Emergency Medical Service in Turkey.
Teşekkür ederim. İlk önce İngilizce sunum yapacağımı biraz önce öğrendim. Behçet Hoca'ya o yüzden biz sunumu Türkçe hazırladım. Behçet Hoca da ceza olsun diye çevirimizi yapacak Behçet Hoca.
Önce bir soru salonda. Who can I speak? You cannot